for 24, 48 hours or more. This would suggest a localized these babies would have guarding on the, when you find a baby has guarding on the right side of abdomen, redness when you examine, and when you see this on the x-ray, which is suggestive of pneumatosis, you know this is possibly an indication for surgery. So some of the relative indications for surgery are worsening abdominal distension and tenderness, discoloration. These by themselves are not indicators for surgical intervention, but in combination with other features are relative indicators for surgery. Portal venous gas, a lot of reference to this portal venous gas, but presence of portal venous gas alone is not an indicator for surgical intervention, but the presence of portal venous gas, it gives a very bad it is an indicator of poor prognosis in that child. So when we consider surgery, now that we've decided on surgery and the birth weight of the baby, the extent of bowel involvement, the severity of the disease, and the management options that you have, and also not to forget the outcome that you have to take. So one reference at this point that these to the bedside surgeries with the present scenario in the NICUs where you have low birth weight babies, very premature babies who are hemodynamically unstable, some of them being on high frequency ventilation. These babies, when they present with necrotizing enterocolitis and they taking them to the main OT for surgery is often not advisable. They have a risk of hypothermia during the transport. When they're ventilated, the tube might get dislodged. So these babies preferably should be operated by the bedside. So we have operated babies being as low as 560 grams, 700 grams in 1 kg, and all of them have we have done a laparotomy and stoma, limited surgery to get through the sick phase, and all of them have done well. And subsequently, later, like 3 to 4 months later, we closed the there's a 10-year review outcome of from literature also, which says that the outcome of critically ill neonates operated in the NICU setting has not changed the outcome at all, has not shown any increase in mortality. So some of the, just to show a few pictures of how the necrotizing enterocolitis is seen on table. It can be a focal perforation, yeah, single perforation, or it can be a large segment which is involved, gangrenous. Or it may be multifocal or multi-segmental. Multifocal or multi-segmental, where more than 50% normal bowel is still there, or it can be pan-intestinal or necrotizing enterocolitis totalis, where there is only less than 25% of normal bowel, which is normal. So the surgical options available to us are either primary peritoneal drainage or primary peritoneal drainage was being indicated only as a primary treatment only for babies weighing less than 1,500 grams, and that was the only treatment offered, surgical treatment offered to these babies in the earlier days. But now, what we do now is we when extremely low birth weight babies or otherwise when they present with massive mobility, we do peritoneal drainage as a primary bedside procedure, followed by laparotomy if necessary after 48 hours. Laparotomy, when you take the baby to a laparotomy for a laparotomy, we have various options such as a proximal stoma, or you resect a gangrenous bowel or perforated bowel and then do a stoma, or you can do a resection of primary anastomosis, or you can close the abdomen and you come back for a second look surgery after 48 hours, or in multiple segments you resect the diseased bowel, clip each one of them and drop them and come back later after about depending on the condition of the baby, you can come back later to do the anesthesia. Or you have something called patch drainage, where the perforations are closed, drains are put in, and you wait, keeping the baby on TPN. And as the baby improves, you can plan on the definitive surgery. When nothing can be offered surgery wise, when the gangrenous bowel, extent of gangrenous bowel is too much and nothing can be done, so nothing can be done both medically and surgically. withdrawal of treatment is the last option we have. A brief mention about role of laparoscopy in newborns affected by NEC. There is a lot of articles on that on this topic. It's something called gasless laparoscopy, wherein you put in a laparoscope to assess the status of bowel and then decide on whether a laparotomy is necessary or not. If the bowel looks fine, you don't need to do a laparotomy. But if there's perforation, peritonitis, you need to do a laparotomy. So how do you manage these babies? When you find a focal perforation and the baby's condition is reasonably good, there's no acidosis, primary bowel resection and primary anastomosis. But if the baby is sick and you think the baby the healing may not be appropriate, then you do not want to take a risk. You can resect the gangrene perforation and then do a stoma. When there is multifocal disease, again you can do resection and multiple anastomosis, or you can do a proximal stoma, or you can do resection and multiple anastomosis over a tube, which can be left as a vent and removed later. So patch, drain and wait, perforation closure, drain. This is a baby I'd like to mention about. This was a 1 month, one of the twins, 1 month old, 1 kg baby who presented with necrotizing enterocolitis, and she was adopted by a well-to-do family. Sadly, the baby had multiple problems. We went in, resected, did a stoma, but then the disease continued. The baby, despite the stoma, had anastomotic leak or a leak from other segments which were not resected. We kept this baby on TPN for a month because the resources were not limited. We were able to pull this baby through that disease, through the course of the disease, and then finally we went in, did a laparotomy, resected multiple segments, did a multiple anastomosis, and this baby went home, and now she's about 8 years old, doing very well, except that she's got some learning disabilities. Pan-intestinal involvement, that is necrotizing enterocolitis totalis, close and second look after 48 hours, long TPN, and this is the options we have. So this is to say how clip and drop technique is done. They use tightening clips, while they use sutures to close the ends. So complications following surgery or stoma, like as anastomotic leak, then wound dehiscence, and stoma, intersection of the stoma. Internal fistula formation also is well. Stoma closure is done when the baby's condition is stable, when the stall rating and stoma is functioning well, there is no ongoing stress. And before closure, a word of caution, check for patency of the distal bowel by doing a contrast study. So the time of closure, stoma closure can be variable depending on the baby's condition. And if there is bowel discrepancy between the proximal bowel and the distal unused bowel, one can offer chimney surgeries. These are the various chimney surgeries, proximal loop, distal loop, or a vent. All these can be offered as an alternative. Long-term complications of stricture confirmed by this is usually seen after non-operative management, most commonly seen in splenic flexure, and present with failure to thrive, progressive distension, dilatation of bowel loops. And in this case, you should suspect a stricture, confirm a contrast enema, and elective bowel resection and osmosis can be done. So, since we cannot do any further progress on the treatment of necrotizing enterocolitis, we should concentrate on prevention. And prospective studies can be done to compare medical and surgical management and different modes of management. Long-term management of short bowel syndrome. We also should look into the neurocognitive issues. There are some articles about various management options for short bowel syndrome. Conclusion: despite all these studies, despite the various trials, necrotizing enterocolitis continues to be prevalent in the NIC worldwide. Approximately half of them will need surgical intervention, and this has to be kept in mind. Various RCTs to compare the outcomes of surgical approach, looking into the mortality of the different ways of management, and also to see the neurodevelopmental consequences of laparotomy. Because there are studies to say that babies who have undergone surgery have a higher incidence of neurodevelopmental consequences. So these have to be looked into the future. These are the references. Thank you.
The session is now open for questions and discussion.
Good morning to all. First of all, I would like to thank the organizing committee for giving me an opportunity to share this important session on necrotizing enterocolitis. Both the talks were very good. In the beginning, it was an excellent talk by Dr. Chandrakala. I know her since many years. She's my good friend. Uh, she she has given an overview of NEC, etiology, clinical features, differential diagnosis and management, and she stressed upon some important aspects like the importance of ultrasonography in the diagnosis of NEC and preventive aspects like the importance of mother's milk and probiotics and antenatal steroids. It was an excellent talk. And if there are any questions on the medical aspects of NEC, it, there's a, on the, it is open for discussion. And now about the surgical.
Thank you, Chandrakala. That was like Virat Kohli completing his century, leaving nothing for us to play around. I think it was quite exhaustive. I, since there are no question, just a comment. I don't agree with you, your statement that pediatric surgeons don't agree with you. Pediatric surgeons are very open. We agree with anything and everything, provided it is logical and backed by evidence. And what you brought up, especially the role, newer things about ultrasound being used and early prevention being thing, early feeding, no antibiotics. Those are something which are really being used now. The second thing, with respect to surgery, there are earlier days like we used to do, like you pointed out about drains coming out of work. Recently, there have been a lot of these studies which have come out with the stressing on the gut-brain axis, which show that the longer necrotic bowel is there, the higher the cytokine response, the poorer the cognitive issues because of the gut-brain axis being affected. So, like you have pointed out, go in early if you have necrotic bowel, remove as many necrotic bowel. At the same time, with newer management coming, replacing small bowel transplant, trying bowel salvage, prolonged support, do as minimum section as possible. Any other questions? I'll leave it to.
Good morning to everybody. This is a question to Dr. Chandrakala. You have told so many things about feeding. Okay. So I want to know mother feeding the ultimate you have mentioned, and alternative you are told animal feeds. I want to know the biological values of cow milk, goat milk, and donkey milk. Nowadays, people come on the road saying for your child, for infant, donkey milk is good, cow milk is good, goat milk is good. What is your comment on this? Please enlighten us.
Thank you, sir, for the question. It is a valid question. Uh, Preterm mother's milk is best milk for the baby. So it is best milk for the term babies. Even preterm babies also we say mother's milk is best. But the need of proteins and calories, the requirement the baby, small baby needs for the growth and development, it is less in mother's milk. Because of that, so mother's milk, along with that, I mentioned about human milk fortifier. So which can give more of whatever deficient calories and proteins and calcium that will provide by human milk fortifier. So even with human milk fortifier, the human milk based fortifier are best. So that is what is so. And mother's milk is best for the baby, and cow's milk is best for the lamb. So like that. So we don't advise any cow's milk, and of course formulas which are made of that. We don't advise at all because that is most important predisposing factor for NEC. And goat's milk, we don't because of the vitamin B12 deficiency. So we don't advise anything else. If mother's own milk first, then donor's milk, especially when our milk bank is available. Second option. Third option, if that is also not available, we go for formulas. Term may be term formula, preterm may be preterm formulas. That's all. So apart from that, we don't advise any other milks. Thank you. It is available, yes.
Powder form may get contaminated if we
Yes,
dilute with
yes.
water or something.
Yeah.
So which is
Uh,
preferable? And you have mentioned 2, 3
Yes,
combinations,
yes, yes.
which may be the best.
Yes, so it is powder form is easily available. It's not expensive also, but liquid form is very expensive. So, but apart from that, liquid form adds to the quantity of the milk. Where preterm babies, we don't want to give more of the quantity, the volume overload. So, powder is advised, and the mainly the combination powder is available. So, liquid form is very expensive, and also the volume. Because of that, we don't. Otherwise, liquid both are okay. Either powder form or liquid form can be
Should we
used.
give it daily or with each feeds?
It is with each feeds. Yes, it is. So when the baby reaches at least from when the baby start feeding, we start using probiotics. So we give that till up to 30 till the baby reaches full feeds, and later also every day each feeds.
Thank you, ma'am.
Thank you, sir.
I now request the chairpersons to felicitate our speakers. Dr. Chandrakala, ma'am, can you please come on the dais? Dr. Padmalata, ma'am, can you please come on the dais, ma'am? I request our speakers to now felicitate our chairpersons, Dr. Rangaswamy sir and Dr. Anand Alladi sir. Thank you, chairpersons. Our next talk for the day will be on snake bite. Medical talk will be given by Dr. Lalita A.V. ma'am. The chairpersons for this session will be Dr. Shivaprakash sir, HOD of Pediatrics Department, DNB Program, Government Hospital, Tumkur, and Dr. Narendra Babu sir, Professor and Unit Head, Pediatric Surgery, Indira Gandhi Institute of Child Health. I request you both to come onto the dais, sir. Dr. Lalita ma'am is MD, DNB, FNB, Pediatric Critical Care.
Good morning, one and all. Thank you, Dr. Subramaniam and the organizing committee for inviting me to give this talk. So we'll move from the neonatal topic to the pediatric topic that I'm going to take you through management of snake bite. Only the emergency topic. One snake bite. Okay. So the learning objective for this is we are going to look at the pre-hospital care, recognize the signs and symptoms of immunomation, and how to manage if a child presents with snake bite to your emergency or to the ICU. Okay. So all of you agree with me that best ways to manage snake bite is to prevent a snake bite. Sorry, I'm familiar with this. So how to prevent a snake bite? It's not almost universally not possible. Can you imagine a world without snake bite? Almost nearly half of a quarter of us would go hungry, and they are very important element of the food chain. So we'll be unable to eliminate snake bite. So which are the most common important snake species in India is what one need to recognize. Especially in India, we got three most common. One is cobra, crate, and Russell viper. The most common being your common crate. The first step, what is the first step? Is to identify whether it's a poisonous or non-poisonous. We have got close to some 300 species of snakes, and of which only 70% of them are poisonous. Most of it are non-poisonous, or it is a dry bite. And only how do you say that it's a poisonous snake is because only when you see there is a or when the patient comes with a severe pain and edema, then spreading rapidly, then it's a venomous. And once we suspect snake bite, one has to observe in the ICU and treat them accordingly. So there is a fatal dose differ from species among snake species. The fatal period is what is important for us. In cobra, 30 minutes to 24 hours is the fatal period, and in viper, it is 1 to 4 days. Sometimes this Death may occur imminently even with a dry bite because of the fear of it not exactly with the snake venom emission. The signs and symptoms, there is various enzymes, proteinases, which causes the issues with the snake bite, and it can involve all the organs. It could be, the CNS system where the patient can present with headache, blurring of vision, or a cardiovascular system where the patient can present with shock, or muscular system, convulsion, and renal failure, and so on. So, how do one differentiate between different types of snake bites? So, you main classification what we have to understand here is whether the patient, whether it's a neurotoxic venom or a vascular toxic venom. So, LRPS and cobra, like cobra and crates are the neurotoxic venom where they present with severe neuroparalytic symptoms. Vascular toxic venom are is viper, where they present with bleeding manifestation. Okay. So let's look at based on the symptomatology, how to recognize the different types of snake bite. So viper and cobra cause severe local pain. Remember that if a patient comes with severe pain, numbness, and edema, always consider if there is a viper and cobra. Suppose if a patient comes with neuroparalytic symptoms like ptosis, ataxia, dysphagia, and broken neck sign, and later on progressing to respiratory difficulty, it is neuromuscular junction of getting affected. The snakes are either a cobra or a crate. So, what about viper? Viper involves systemic manifestation. It causes like hematological, where the patient can come with severe bleeding or a nephrotoxic. Patient can land up in the renal failure or a cardiotoxic in the form of shock. So, right. So this is a patient. In addition to nephrotoxic, cardiotoxic, and renal failure, this patient also has had a neuropathic symptoms. So this all is possible in viper. So the first aid treatment, a brief overview. I think all of you must be familiar with this mnemonic of do it right, isn't it? Yes. What is right? R is reassure the patient. Exactly. I is immobilize without compression, same as the way you immobilize a fracture, where a splint has to be applied and the tourniquet can be tied. It should not be too tight, not should be too loose. Where if it is too tight, can cause ischemia. Okay, and two use is of no use, and the G and J get to the hospital immediately and tell the scientific doctor. So there are something don'ts which we have to remember. The don'ts are, generally this patient would have already done before, or the patient attendants would have already done before the patient is brought to the hospital. But these are something which are not advisable, like do not wash the wounds, do not apply tourniquet where the limb can go into ischemia, do not incise the wounds where the envenomation can become rapid, can rapidly spread, or do not apply the suction to the wound or anything. So ASV, when to give, do all the snake inhibition patient present with that require ASV? Yes or no? The answer is no. Some of 50% of the bite are all dry bite. There are only certain indications where ASV has to be given, recommended by WHO. If the patient presents with systemic envenomation, like if a patient has got a whole blood clotting time, it's a bedside test, it's a 20-minute whole blood clotting time, where you take 1 to 2 ml of blood in a dry glass tube and allow it to stand for 20 minutes and check whether it is clotted or not. If it is prolonged, yes, that is an indication for giving AFP. Systemic bleeding. Patient comes with systemic bleeding or neurotoxic signs, which I already mentioned earlier. Sometimes there can be just a local pain or without any swelling. That is not an indication. Only if a severe current local swelling is present, that is half of the bitten limb in the absence of tonic. If it's already crossed a joint, rapidly crossing joint, severe edema, severe local pain swelling is an indication for AS. So how much to give? This has been a question answered over since last decade that it was already classified as mild, moderate, severe. The WHO has completely framed out and they have said either it's a systemic envenomation or no systemic envenomation. So any sort of snake envenomation, if the patient presents with all those previously mentioned signs and symptoms, then you have to give ASV around 10 vials. It should be administered as quickly as possible within 1 hour. And remember, there is no need to test for ASV test dose. It is available as lyophilized powder form. So, how do you infuse? It's reconstituted. The ASV is diluted in 5 to 10 ml per kilo. Suppose the patient is around 10 kilos, I have to reconstitute 10 vials in 100 ml. It has to be infused as quickly as possible. The constant speed, and there needs to be a closely monitor. You can give that even in emergency. As I said earlier, there is no test dose required for administration of ASV. So when do we repeat? The next question which lingers in my mind, okay, I've given ASV and I'm monitoring the child and the child is not improved. Should I give ASV? Again, there are specific set of criteria. You have to reassess for any unimproving signs. Suppose if it is a hemotoxic bite, many a times the patient comes with some snakes or vipers in their hand, you can identify. Or if the WBCT is prolonged more than 20 minutes, and if that should improve within 6 hours. So you have to repeat this WBCT test after 6 hours. There is no improvement, even though if the child is asymptomatic, you have to administer ASV. Suppose if it is a neurotoxic bite like crate or cobra, then within 1 to 2 hours, there should be an improvement in the neuroparalytic symptoms. If there is no improvement, one has to administer ASV. So, how much? The upper limit is this is what has been described at WHO. For viper, it is around 30 vials, and for neurotoxic, it is around 20 vials. So, remember this. So, if we have to repeat ASV for a viper after 6 hours, and you can go to 30 vials. For neurotoxic bite, within 1 to 2 hours, one should see an improvement in the neuroparalytic symptoms. And if patient doesn't improve, you can give one more 10 vials of ASV. It is not indicated for any local non-progressive swelling or isolated thrombocytopenia or renal failure. And remember that ASV is of no use after 4 days. So, the patient comes after 5th day or 6th day and is still having some symptoms, benefit of doubt, we still give, but remember that it's of no use. So, do we have to take precaution during ASV administration? Yes, the answer is yes. But as I said earlier, do not administer test dose because that is known to delay the administration. It has to be given as quickly as possible, but one has to monitor for anaphylactic reaction. So, this is the whole blood clotting time, which I had already mentioned earlier. This is what you can see, 20 minutes. You have to watch for this WBC test to be positive, whether it is clotted or not clotted. This is a patient where you can see a control at the test. In the control, it is not. It is clotted in the test. In the patient, it's not clotted after 20 minutes. So let's quickly. You got a overview of snake venomation and how to treat. I'm going to take you quickly through the case scenarios and see what we can do with these children. So this is the first scenario. This boy, a 10-year-old, was brought with a history of snake bite at the right time and had severe pain at the site of the bite with progressive swelling. When the child was immediately rushed within an hour after snake bite, and the mother had already tried the tourniquet. So in any pediatric emergency, we follow this PAT triangle, that is pediatric assessment triangle. Which contains ABC, that is appearance, workup, breathing, and circulation. So any emergencies, one has to follow this triangle, and we can make decision whether it's a systemic invasion or local invasion or any of the complication. So in this child, appearance was alert, tone was normal, airway was stable. He was breathing slightly fast, though, but no retraction of circulation seemed to be fairly normal. So cardiopulmonary cerebral assessment was normal. But if you look at the so what has happened to the limb? Is the edema crossed the joint? Can you all of you appreciate this? The swelling has increased, the edema has crossed the joint, and there is mild pain. So is there signs of envenomation? Do you want to give ASV? Yes? Okay. So this is a sign of envenomation. As I said earlier, the local pain is quite significant in patients with cobra bite or sometimes in viper bite. So in this patient, WBCT test was done and it was prolonged, and so this child was given ASV or was administered in this child. So in addition to ASV, that is a specific treatment. One should not ignore certain other measures like administration of tetanus toxide. Sometimes you may have to give prophylactic antibiotics depending on the swelling and all, because this saliva of the snake can contain some anaerosols as well. And remember to re-evaluate WBCT test after 6 hours. So in this child, ASV was given. 30 minutes following the ASV, this child developed itching and rash. I'm sure most of us would have encountered this sort of situation in your emergency whenever you administer ASV. So what's happening in this child? Anaphylaxis, isn't it? So yes. So anaphylaxis is quite common during administration of ASV. So what you have to do, you have to immediately interrupt the ASV administration and give all your anti-anaphylaxis treatment like administration of your adrenaline, hydrocortisone as to be administered, Avil has to be administered. And then if the patient develops severe anaphylaxis like angioedema, shock, one need to take care of airway, breathing, and circulation. So support the airway, support the breathing. If the child rarely might require intubation also or positive pressure ventilation, and if the child has got infused with crystalloids. But remember to restart the ASV because that is the specific treatment we have got for sleep remission at a slower rate. Maybe for 10 to 15 minutes, keeping the child under the close observation. So at any point of time, the ASV cannot be stopped at all. Even if it's anaphylaxis, treat anaphylaxis and restart the infusion. So this is a second scenario. A 12-year-old girl rushed to the ED following a snake bite or a right foot. During the night when she was sleeping in the open field, she was lethargic, breathless, and her WBC test was positive. This is the okay. So appearance-wise, she is responsive only to pain. But this conjugate nystagmus was present, and she was tachypneic. Mild tachypnea was present, and she had signs of shock. Signs of shock we say if the patient has got tachycardia, prolonged CFT, with or without hypotension. So cerebral assessment is normal, abnormal, abnormal, right? If their WBCT was prolonged, is there a sign of attenuation? Yes. So you think can you suspect which type of snake has caused all this? Most likely, this child has WBCT abnormal. Generally, cobra does not cause so much of hemotoxicity, mainly the viper bite. So shock can be a present because of cardiogenic or a hypolemic or neurogenic. Management-wise, yes, specific is ASV. In addition to that, take care of airway, breathing, and circulation. And repeat WBCT after 6 hours. And in this child, WBCT was still prolonged, so we administered ASV up to 30 hours. And suppose if the bleeding persists, one has to give your FFP or cryoprecipitate to stop the bleeding. Quickly, I've got 2 more scenarios. Do you have time? Yes. Okay. So this is the third scenario. I don't know. Audience are very quiet. If there is a snake bite, attenders will also be jumping, and even we'll also be very hyperadrenergic results will be there, isn't it? Yes. So this is a third scenario. A 1-year-old boy rushed to ER with history of snake bite while playing in the garden. He complained of pain and swelling at the site of bite. Fang marks was present, swelling was present, and he had sepsis. As an appearance wise, airway was stable and circulation was stable. So airway was stable, just that he had ptosis, but he still not progressed to respiratory failure. So cardiopulmonary assessment was normal with ptosis. Yes, ptosis is an indication of neurotoxic. One has to administer ASV immediately, otherwise, especially in the cobra bite or in the grade, slowly progress into respiratory failure requiring intubation and ventilation. So another very important thing is when you suspect neurotoxic bite, apart from administering ASV, you can also give specific management for neurotoxic. What is that? Can we try any drug here? Have you tried it? Neostigmin? Yes, especially in cobra bite, the postsynaptic, inhibitors, where the cobra has got a lot of this anticholinesterase, which is very neostigmin is effective in reversing of neurotoxicity. To administer neostigmin, the dosage is 0.04 milligram per kilo of neostigmin. Make sure you always give in with atropine in order to combat the side effects. Suppose and look for the reversal. Reversal means improvement in the neurotoxic symptoms. If there is no improvement, don't have to administer. If there is improvement, continue till the neurological recovery happens. So then the other case scenario, 4-year-old rushed to the ER with unconsciousness. Otherwise, he was normal. There was no history of, in fact, a snake bite. There is no history of fever or any infection, and just the swelling was noted. So, and this is what this child came with total comatose child. In between, he was posturing also. He was unresponsive. All time movement was absent, was defective, and he had unmaintainable airway. So, always suspect history of snake bite, especially if there is no history of trauma or infection, and if a patient who is apparently well comes the next day with some neurotoxic symptoms. So there was some swell, and one need to have a careful evaluation of the end. That ABCD is there, so E is for exposure. check for any fang marks, check for any swelling. So this child came, had cardiopulmonary cerebral abnormal. He was in failure with signs of severe envenomation. So the management wise, yes, ABC and specific management with ASV was given, and this is what we did: bag and mask, we intubated, we gave ASV, and this is the next day this child was extubated from the ventilation and they recovered. 2 days later, we discharged this child. The last scenario, a 10-year-old boy rushed to the ER with history of snake bite in the right forearm. He is complaining of slight pain. This is the pain, and there is no swelling. His WBCT was normal. Hemodynamic stable. Appearance, breathing, and circulation, everything seems to be stable except for small swelling in the joint. So, do you want to administer ASV in this particular child? We are very clear, isn't it? Just local pain? No. Swelling is not crossed the joint? No. No systemic symptoms? No. So the other thing which one has to watch out is for compartment syndrome. The surgical colleague will be addressing this compartment syndrome. So I'll quickly move on to the algorithm approach of the management of snake bite. So how do one manage a case with snake bite when the child presents to ER? Always make sure to follow that same pat triangle appearance, breathing, and circulation. Suppose a patient is everything is normal, A, B, C, and has got cellulitis. So looks like it is a stable bite, but he has got cellulitis across the joint. So what do? You will give ASV. Yeah. Second patient. This is a patient, appearance wise, he's tone, everything normal, respiratory is normal, but is and even circulation is also normal. WBCT is prolonged. Make sure you do WBCT test. So, what do you think is happening in this child? Immunization present or absent? Present. Which in snake we are suspecting here? Viper, hematotoxic, right? So, Viper, administer ASV and repeat the WBC test after 6 hours. If required, if it's still wrong, one has to administer. So, the next case, appearance, all neurotoxic symptoms are there: dysarthria, dysphagia, ptosis, breathing is normal. Otherwise, breathing is increased, circulation is normal. So, neurotoxic, either it can be cobra or crate. So, you may, in addition to ASV, one may have to consider neo-stigmine test. Sometimes you do get a scenario of unknown bite. So, high index of suspicion of asking where the child was sleeping, or especially in the crate, overnight, it just things, and it's a painless bite. So always suspect history of snake bite in case of unknown bite, and look for the systemic symptoms. In this child, the patient had appearance was also affected, breathing was abnormal, and shock was present. So, in addition to air, breathing, circulation, and specific treatment, you take care of shock, take care of systemic complications. So, the key points: first and foremost, relieve anxiety and reassure victims that fatality is minimal. That is very, very important. Snake, whether it is patient or doctors, all of us are scared, isn't it? So always don't panic and tell the same thing. Reassure the parent as well. Watch out for cellulitis and hemostatic abnormalities, which are hallmark of a bite. And neurotoxic symptoms for elapid envenomation. Do a bedside WBC test. You don't have to do, complete blood count, LFT, RFT, not required, right at the presentation. Just that WBC test can suffice. And later on, suppose the child is having, look out for any complication and then plan for investigation. And it's a myth that children are small and they should receive, less dose of ASV. Answer is no. Snake doesn't differentiate whether it's a child or an adult. It always bites with the equal amount of venom. And remember to give ASV only if it is required, if there is signs and symptoms of envenomation. So this is a summary of the different types of snake which we commonly encounter. I'm sure in India, it's only cobra, crate, or rustic. So that's it. Thank you for patient listening. I think we'll take the questions after the surgical talk. Thank you so much.
Thank you, ma'am. The surgical talk on snake bite will now be done by Dr. Santosh Gurdeep sir, MS, MCH, DNB, Professor and Head, Department of Pediatric pediatric surgery, Kehrs JN Medical College.
Thank you, madam, for nice presentation. I'd like to pay regards and my respects to my National President Ramesh sir, Secretary Vicky sir, and past President Dasmit sir, and also the State Chairman Narendra sir and Secretary. I will deal with the surgical aspects of the snake bite in short. The topic has been well covered by Lalita madam. So coming to the introduction, it is a life-threatening and what is important, it is a time-limiting medical event. So we have to attend it. Mortality is very high, but what is important here is the surgical morbidity is also even higher. There are over 5 million persons being bitten by snakes every year, but more than 1 lakh of them suffer from severe morbidity, which are related to the bone complications. We have national snake bite protocol, WHO protocols, but there is no evidence-based guideline for management of the local. As said earlier, we have those big four snakes which cause this. Only 20% of them reach the hospital early, and of these, again, 20% have already considered so-called traditional killer. And victims are not diagnosed easily, and they may be misdiagnosed of a GE, appendicitis, a food poisoning, bacteria, or even a TB syndrome in these patients before we find a definitive diagnosis. And we have so much literature on this, which are titled just to prevent episiotomy or surgery in these snake bites. We are not debating this, but we'll go to the data and guide. Uh, what is the management is the protocol based. First is the first aid treatment, then transport to the hospital as early as possible, rapid clinical assessment, and start the treatment along with the investigation. What is important is the supportive treatment in the form of surgery and follow-up and rehabilitation is also equally important. This is a protocol which was dealt earlier. This is the ASV, which has vaccine, which is against four important snakes. The toxic effects are due to the enzymes, and the cobra bites cause neurotoxic, but some local effects. But the main local or wound complications are the viper and the saw skin viper. There are grades starting from grade 0 to grade 4, and the grade 3 is the grade 4 ones, which will require even the local wound management. And out of the second algorithm, first one, the progressive painful swelling, which may lead to the compartment syndrome, and the last one, myotoxic toxins, which can also lead to the compartment syndrome and needing surgical treatment. We feel some things which are not to be done. That one of them is a tourniquets. Why it is contained in it is the necrosis and loss of limb if tied too tighter. If it is tied loosely, then it won't work. So they do not stop the poison from escaping to the systemic region. So hence, it is said that it is better not put than used. Then methods like cutting, washing, suction are also to be not to be used because they do not prevent the poison being absorbed and they do not cause the venom to be removed. Even washing, incision, suction, rubbing, and touching will increase the blood supply there and improve the circulation and cause the poison to be absorbed early instead of being decreased absorption and also produce local wound problems and increased bleeding, hence contraindicated. Then so-called electrical therapy and cryotherapy are also contradictory because they have been of much use in 1980s and 90s. But it is said that the current denatures the venom, but it is not true, and it may be contradictory and help the poison to get early, and the patient may even suffer other injuries. And cryotherapy does more harm than being there is something called traditional remedies. We still have these traditional healers where the patient goes to them, and then if it is a poisonous snake bite, then it is referred. This is how it works. Like a simple mathematics. Like if there are 100 snake bites, and we know 70 of them are non-venomous or non-poisonous bites, and 30 who are having poisonous snake bite, out of which 50% are dry bites. Dry bites means there is a snake bite, but there is no venom injected into the body. So only 50% of the 100 babies who have been bitten are actually poisonous, who are going to get affected. And the 85%, if they are staying with this traditional healer, they are going to get better. So this is mathematics how they tell we cure snake bite. So with the traditional healer will only refer if he finds the poisonous bite, and so we have to discourage such practices in our community. Coming to the surgery proper, there are when we need surgery, and one of them is the painful progressive swelling, which is seen with the vipers and even saw scale vipers. This is indicative of local venom toxicity, and there is local necrosis, and there is an abnormal smell. These patients, when they come, the limb is swollen, the skin is shiny, there are blisters, there is ecchymosis, vascular involvement, and they may proceed to compartment syndrome. Another issue where they may go to compartment syndrome is fire toxicity, where it is seen with sea snake bites, and they present with muscle swelling, edema, compartment syndrome. They also have hematuria or dark brown urine, myoglobinuria, and they may develop compartment syndrome needing treatment. Due to the acute compartment syndrome proper, where there is an increased pressure in the compartment which is enclosing the muscles, vessels, and the nerves, and it has no clinical reliable indicators. So it has to be scientifically proved that it is there, and then we can go for facial tones. There are the 6 P's which are also true for the vascular insufficiency, like the pain, pallor, paresthesia, pulselessness, decreased temperature, and paralysis, which are also true for acute compartment syndrome. Only two are enough for the diagnosis of compartment syndrome clinically. The local ecchymosis, necrosis, bulle, and presence of fever, and which is seen with poisonous snake bites. And what will help us is also the absence of blood flow on Doppler, and the decreased capillary filling time, pallor, which will help these patients diagnosed as compartment syndrome needing surgery. Additionally, these patients who are very sick, those who are on ventilator support, on inotropic support, those who have abnormal coagulation parameters may need urgent surgical intervention. So suppose if these are undiagnosed, untreated, or if they are treated late, they may go for amputation, the joint contraction, because the damage is osteoarthritis. So when is fasciotomy needed? It is more so when the patients present late, those who receive ASV late, or in upper limb, because there is early entry of the snake venom into the deeper compartment early. Then how to pick up? One is clinical, second is ultrasound, where it will show the poor vascularity by Doppler, and third is by directly measuring the compartment pressure. It's one of the methods which can be done bedside, where the 60 needle can be directly uh, inserted into the compartment, and the pressure measured by centimeters of water. So the fasciotomies should have the knowledge about the anatomy of the compartments. In the leg, there are 4 compartments: one anterior, posterior, and deep, and one lateral. Forearm, again, 4 compartments. Arm, we have only anterior and posterior, and in thigh, we have 3 compartments. So each compartment has to receive a big lever so as to relieve the pressure from the compartment and save the muscles, vessels, nerves, and even the limb. So how does this proceed? Is their sensory deficits are earlier than the motor deficits. Is a classical woody feel of the compartment syndrome, and the pain is very disproportionate. There are no local signs, but the pain may be severe in these children. And if there is a extension or flexion of the limb, which induces passive stretch of the muscles, and there is severe pain, such as compartment syndrome. And before you go out with the surgery, the coagulation file should be corrected. What is important is have a good liberal incision, and we should cut the deep fascia, and the muscles should go out. And afterward, the dressing is important with the antilators. They may or may not require additional suturing or grafts. These are the fasciotomies of the lower limb. You can see the muscle bulging out of the wound. Fasciotomy of the forearm. So that the closure is easy, we take a zigzag incision. There are other therapies in these cases of snake bite. Some of them are listed here, like simple incisions of the skin, that is dermatomy, then fasciotomies, then debridements later, which is usually needed after 5 to 7 days of snake bites. Then there are sometimes eyes, especially the cobras, can splash venom even from 1 meter from the child or an adult. So that can also lead to neurotoxic events and even death. And later, techniques are wound therapies, vacuum or negative pressure therapies, even skin grafts and pedicle or feet grafts. Coming to the discussion, it is mainly about this fasciotomies in these children. So it was Chattopadhyay who reported 24% of these patients required surgical intervention. And in studies of South Korea, it was about 10 to 40% of them required surgeries. And those are the patients whose the intracompartmental pressure was more than 40 millimeters of mercury. In other studies of Taiwan, the incidence was as high as 45% who required surgery in these snake bites. What we see is the early surgery mitigates the progression of edema, inflammation, necrosis by reducing 10 tumor necrosis factor. And what also helps them is continuous monitoring of clinical signs, that is color changes, reduced safety, increased swelling, and as said earlier, the pain which is disproportionate to the signs. And without waiting, physiotherapy would help these patients. And most of the institutes, we still do not have equipment to measure the compartmental pressures. Clinical equipment and software helps in these scenarios. Why early surgery? There is a high mortality with illumination, but the morbidity is very high, and with 10 to 44%. The local signs may not be limited just to local pain, swelling, cellulitis, infection, necrosis, and coagulopathy. Even compartment syndrome may occur and lead to deformities later. There are a wide range of complications which are attributed to the venom, availability, delay in admission of these patients, poor healthcare systems, infrastructure, and patients of low social status, and of course, the delay in surgery. To conclude, the management of sick in children faces significant challenges as it mainly affects those in rural population and those from the low socioeconomic groups. So we do not reach or we reach late, and we need surgical therapy. What is important is snake will not inject venom in a child. Therefore, they also do not require lesser dose of, as I said earlier. And the community education of shift first hospital intervention will which is to remove all the devitalized or necrotic tissue and do fasciotomies and later reconstructive procedures to minimize the functional loss and maximize the rehabilitation. However, the pediatric cases are challenging to manage, and we need much work on and research on these ancillary therapies, including surgery, which is very important. Thank you.
Thank you, sir. The session is now open for discussion.
I congratulate both speakers. I think it was very good. Session is open for discussion. So, any questions we can take?
It was excellent talk by both the speakers, Dr. Lalita, medical management, and Sir spoke about surgical management. Especially the last point, an unconscious patient is a real challenge. Sometimes it can lead to medical legal problems, which recently happened in our government hospital, Tumkur also. So one should be very careful in identifying the snake bite in an unconscious patient. That's very important. And one more point is 20-minute WBCT is a very useful thing, but sometimes we find it equivocal. So sometimes we need to do PT, APTT also to augment this test. And we refer our so many children with facial compartment syndrome to the Subramania team here, and we are getting excellent results by the department. Thank you.
Santosh, have you used that the intra compartment pressure monitoring?
Yes.
The same device what you showed. Is it?
And they did not want surgery. We had to prove them.
So is it
very difficult, sir?
Reliable?
Very difficult, sir.
Okay.
Not get the results from the remote.
Okay. So other thing is, madam, just for this out of scientific question. So the minimum dose is 10 vials and then repeat dose is 20, 30 vials. But what is the reason of making the small vials? Can they increase the dose and make the manufacture itself better? So that each vial has got, say, some specific dosage. If you want to give minimum of 10 vials for any vial, why don't they make it as a bigger vials only? Manufacturing.
It is too costly for the government, sir, and most of them have reaction, sir. That the small vial. Reaction is there with desensitizer and.
No, that's a very good suggestion. In
question
fact,
is right.
I'm Dr. Lingegoda. I'm basically anesthesiologist and currently vice chancellor. That's a very good suggestion what you're suggesting, because once in a while, whenever you get, even in OP poisoning, we face the similar situation, cutting almost 50 hundreds of atropine ampoule. So if it is available in preloaded vial form, it's very useful. My question to you, doctor, it's a very good presentation. I just wanted to know that what the difference between adults and pediatric age groups as far as snake bite is concerned, because these guys have a smaller body size.
Venom injected is same, sir. So the ASV is also same. The most important thing is the injection of the ASV, sir. And the fasciotomy, sir, we have to go by clinical criteria, sir. 6 P's, and then the 10 slim. It is a woody feel there, and then the pulse. There is pulselessness, sir, and there is capillary filling time will reduce, and then we have to go ahead with fasciotomy to prevent the lymph. We have seen even amputations in these patients who are referred leads.
Santosh, so like say the Doppler, the pulselessness and no flow in Doppler may be a lead sign. And then this intra-compartment pressure monitoring is not reliable. What's the, like say, is there any role for, like say, looking at the VPG or the pH and glycols in the peripheries, puncture and do a blood gas analysis of the blood, which is comes out, it tells that
Yes, sir. These
is really
are anemic. The coagulation profile has to be done, sir. If glucose is really low. Because there are some instances of death, literature shows death who have bled from the fasciotomy wounds. So it is a very dicey thing whether to go or do not.
still be abnormal. Coagulation profile may be abnormal.
But if it's a snake bite, definitely the fasciotomy helps.
We now end the discussion. I request our chairpersons to kindly felicitate our speakers. Dr. Lalita A.B. Ma'am. Dr. Santosh Kurbet, sir. I now request our speakers to kindly felicitate our chairpersons, Dr. Shiva Prakash, sir, and Dr. Narendra Babu, sir. We will now be starting the inauguration ceremony in another 5 minutes. A warm welcome to one and all. We will now begin the inauguration ceremony. I now request the respected dignitaries to come on to the dais. Dr. Lingegowda KB Sir, Vice Chancellor, Sahe Group, Tumkur. Dr. Ramesh Babu Sir, President, IAPS, Chennai. Dr. Vikesh Agarwal Sir, Honorable Secretary, IAPS, Jabalpur MP. Dr. Narendra Babu Sir, Chairperson, IAPS, Karnataka State Chapter. Dr. MZ Kurian Sir, Registrar, Sahe Tumkur. Dr. GN Prabhakara Sir, Vice Principal, SSMC Tumkur. Dr. Subramanya Kattepura Sir, Honorable Secretary, IAPS, KCS Tumkur. KS. Dr. Yatindra N. Sir, Pediatric Surgeon. Sir has served for and also been one of the reasons for establishment of Pediatric Surgery Department in SSMC Tumkur. Dr. Dasmeet Singh Sir, Past President, IAPS. We will now have the invocation song by Dr. Aishwarya, Pediatrics PG.
ವಿಘ್ನೇಶ್ವರ ನಿನಗೆ ಪ್ರಥಮ ಪ್ರಣಾಮ ವಂದಿಸುವೆ ನಿನ್ನಯ ದಿವ್ಯನಾಮ. ವಿಘ್ನೇಶ್ವರ ನಿನಗೆ ಪ್ರಥಮ ಪ್ರಣಾಮ ಸ್ಮರಿಸುವೆ ನಿನ್ನ ದಿವ್ಯನಾಮ. ವಿನಾಶಕ ಬುದ್ಧಿ ಪ್ರದಾಯಕ ವಿದ್ಯೆಯ ನೀಡು ಹೇ ವರದಾಯಕ. ವಿಘ್ನ ವಿನಾಶಕ ಬುದ್ಧಿ ಪ್ರದಾಯಕ ವಿದ್ಯೆಯ ನೀಡು ಹೇ ವರದಾಯಕ. ಚರಣ ಕಮಲ ನಿನ್ನ ಪೂಜಿಪೆ ಅನುದಿನ ಪಾವನಗೊಳಿಸು ಈ ಶಾಂತಿಧಾಮ. ವಿಘ್ನೇಶ್ವರ ನಿನಗೆ ಪ್ರಥಮ ಪ್ರಣಾಮ ಸ್ಮರಿಸುವೆ ನಿನ್ನಯ ದಿವ್ಯನಾಮ. ವಿಘ್ನೇಶ್ವರ ನಿನಗೆ ಪ್ರಥಮ ಪ್ರಣಾಮ ಸ್ಮರಿಸುವೆ ನಿನ್ನಯ.
Thank you. I now request Dr. Subramaniam Sir, HOD Department of Pediatric Surgery, SSMC, to welcome the dignitaries on the dais.
Good morning, one and all. Good morning, all the dignitaries on the dais and off the dais. It's a great day for us. It's our 18th annual Pediatric Conference Day. So happy about it. So we have dignitaries on the dais. I welcome our national president, Dr. Ramesh Babu. He's come all the way from Chennai. He's a double doctor. He has done his PhD in pediatrics urology, his MCH, and his PhD in urology. He's excellent in his academics. He's come all the way from Chennai. He's a professor of pediatrics at Sri Ramchandra Medical College. Please welcome, sir. Next in the list is our National Secretary. He is Dr. Vikesh Agarwal. He's from Netaji Subhash Chandra Bose Medical College. He is a professor and head of the department. He's come all the way from Jabalpur. So please give him a big round of applause. Next is our past president, Dr. Dasmit Singh. He's a professor at BJMC, Pune and Sassoon College, Pune. You take probably a day to read his CV. He's got excellent CV. He's a big man in our field. Please welcome him. Next comes is our my mentor, Dr. Narendra Babu. He's professor and head of the unit at Indira Gandhi Institute of Child Health. I remember him sitting with me for hours to teach surgeries. He's got, I should say, mountain of patience. He's the epitome of patience. He's an excellent teacher. Welcome him onto the stage. Then we have ours is deemed university. It's a NAC accredited A plus grade university. We have our office bearers. The first in the list is our Lingegowda sir. He's our ex Kidwai director. He's an anesthetist and a critical care person. He's now taken charge as the vice chancellor. After he assumed the office, we got NAC A plus accreditation. I welcome him. Next to welcome is our Korean sir. He's our registrar of the university. I know him for many years. He's fondly called as our storyteller. So, including our Chancellor, sir, calls him as a storyteller. Every time he comes onto the dais, he comes up with a small story which has got absolute meaning. So, I welcome him today. So, probably you can see a glimpse of it even today. Next to welcome is our Vice Principal, sir. Again, we call him his Prabhakar, sir. We call him Tiger Prabhakar, sir, because of fond memories of our old film actor, Prabhakar. Yatindra sir, with me for many years in this college. After his 70 years of service, he has gone back to Bangalore. He has helped me in doing a lot of surgeries. He used to stand with me, assisting cases. Key persons in building the department in this college. I welcome him. Very important aspect of this inauguration was our Chancellor, sir. Chancellor sir is our deputy, ex-deputy Chief Minister of Karnataka. And now he's at the helm of response, helm of affairs, of internal security for the state. He has a function at his constituency today, so he'll not be able to attend this program. So sorry for that. So now may I request all the dignitaries to give a motion to the function by lighting the lamp, please.
I now request Dr. Lingegowda sir, Vice Chancellor Sahe Tumkur, to address the gathering.
Namaste. Good morning, everybody. To organize this kind of major event, especially in super specialty, I know how difficult it is. Because whenever Dr. Subramaniam and Dr. Nikhil Mat wanted to meet our Chancellor, I happened to be there. Only I know how difficult it is, especially to get people from across the state and across the country. And I'm really happy to know that our national president has done PhD, because not many medical personnel in our field think that just because we're getting either MBBS or MS or MCH or DM means we are superhuman beings. But in spite of that, I asked him, when did you do? He's a very intelligent guy. During the COVID period, he has utilized his time. So he has not wasted his time watching, sitting in front of the TV. So I'm happy to know that our own person from Indira Gandhi Institute, of course, in Kidwai for 20 years, I know how many patients you get, especially the regional pediatric surgery institute. They are doing excellent work, and each one there we have come done so much work in pediatric surgery. Because see, before that I worked in Manipal. Dr. PLNG Rao, who is advisor, who was provost chancellor. Being a pediatric surgeon, I still remember, especially pediatric cardiology, how difficult it is to anesthetize. I was just remembering putting an arterial line for the pediatrics. How difficult it is. You're not called here? Not Gangadhar. You should have called all our postgraduates. Huh? Because to listen to them, because each one of they are textbooks with 3 decades, 4 decades of experience working in different areas, different specialties. And I'm happy. I want to congratulate my team, Professor Subramania and Nithumat and the entire team of pediatric surgery. In fact, I was at Bangalore. It was me, sir, I must come here for this inauguration. I'm happy that this kind of event to organize in Chennai or Kolkata, it is very easy. Just give it to some manager because we are in the rural area. And just a few weeks back, one team had come from USD, from Buchanan University. When he went around the hospital, he really got impressed the way we're doing excellent work, especially in nephrology, cardiology. And he has sent an email, but just 48 hours back, we completed our convocation. We had put his message. He was so happy. And in fact, I'm happy that Dr. Subramaniam, in line with our president, Ramesh Babu, you have to register for PhD under Sahe, because sky is the limit to learn. Yeah. Dr. Vikesh Agarwal, he has traveled all the way from, we are extremely happy to have you here. And I'm sure you will be here for another 3 days. Kindly visit some of the facilities which are available in our Sri Siddhartha Institute. Especially, I request our friend Tiger Prabhakar to take it to, especially that our it is one of its kind which you will never see anywhere else. And on the way, while you are going for tomorrow's this get together, kindly visit our engineering college library also. Nowhere you will see that kind of stuff. We've got excellent team. I wish you all the best, and I congratulate all my colleagues who have organized this event in this magnitude. I know you might be small in number, but your expertise, because you can get MBBS graduates or MS graduates, but to do MCH, I have really seen as an anesthetist how difficult it is. I'm sure, sir, which college you did MCH? Okay, so you must have had sleepless nights. You guys, you are not feeling now. I'm telling you, those days are different. You will be getting n number of patients. Immediately they have to attend. So when you have worked, because see, to come and sit in this chair itself, that shows that how much they have worked. Please make use of their presence. And I request Dr. Prabhakar to get all the, both anesthesia, surgery, pediatrics, postgraduates to listen to their lectures. Because it's very difficult, because of course you might say that I can get it in YouTube, but talking with them personally makes a lot of difference. From Sri Siddhartha Academy of Higher Education, I wish you all the best. We'll be with you in the coming years. Dr. Subramania, I am part of your speaker. Thank you. I wish you all. Thank you.
Thank you, sir. I now request Dr. MZ Kurian, sir, Registrar Sahe Tumkur, to address the gathering.
Good morning. In fact, first let me congratulate Subramania team for organizing such a big event in our campus. State level conference in SSIC is a great uh, achievement as far as education is concerned. So I congratulate you for taking a lot of interest and bringing this team here and inaugurating in our campus. And secondly, I just thank all the organizers to accept this Tumkur place. So now Tumkur will be globally known. That is our interest. So not only SSIT, SSMC, but Tumkur should be known. Once Tumkur is known, SSMC will automatically be. So such opportunity has given us to the university and campus. I am very glad and thankful for doing it. And moreover, we have become A plus. Such activities is a must for us. That is the most important thing. And Subramania, when I read his full name, Subramania Kattepura is very well known. His father was my mentor, and he was the vice chancellor of this university for a few times. So I know him since long, and that name, because I have the mentor for now, that conference, he is also with me here in this campus. It's a great honor for me. And I have my friend, Nijgal Mutt. He is also my family friend. I know him very much. And he studied his MBBS here, PG here, and he has come back to this institution. A good team of pediatric surgeon, and this conference is going on here. And now I am held up because somebody must said that I am a storyteller. I have not prepared for it, but I have to tell you, that is a it may not be related to pediatrics or medicine. See, there was a great generator in a hydropower, and suddenly it was an important generator, and it suddenly stopped. All the engineers in the country came and tried to find out the problem what had happened. So somebody said, you have one Mr. Subramanian in definitely the name in Bombay. He's an expert. We just simply try to bring him here so that I think he can give a suggestion for it. So he was brought from Bombay on the flight, and he came. And gradually, as doctors always looks at the patients and take this case and diagnose. I want to come to that. So he will come and just go around and ask him to get a wooden hammer, and he will say, "You hit with this hammer hard at this point." Of. So as per the instruction of Subramaniam, the person came and hit the arm, and he asked him to start. Let's start. And he gave a bill for 1,10,000 rupees. So then the administration asked, "What was this? You are charging so much. You didn't do anything. You just came, saw, and asked him to hit here." He said, "My professional charge is only 10,000 rupees. Professional charge is okay, but any professional should know where to hit and how to hit. For that, I charge 1 lakh rupees. Because without dismantling it, I was able to diagnose and saw that generator was started. That is the truth of all doctors. I know once you see the patients and try to do their this, you will diagnose, and then they go for verification and give the such the capability of doctors. Doctors are called God. I'm not a doctor because you save a lot of life. So all the best. Thank you very much for bringing me here.
Thank you, sir. I now request Dr. Ramesh Babu, sir, National President, IAPS, to address the gathering.
Honorable Vice Chancellor Dr. Linge Gowda, Registrar Dr. Kurian, past President Dr. Tavmeet Singh, Library Secretary Dr. Vicky Shakarma, Karnataka State Chairperson Dr. Narendra Babu, Foreign Exchange Secretary Subramanian, Prabhagar, Ratindra, Secretary who is also EC member, dignitaries on the stage and off the stage. It gives me great pleasure to stand here representing the voice of 1,000 plus pediatric surgeons of the great association of Indian of Pediatric Surgeons. At least 500 members are youth, and they are the futures of this association. So they have some dreams and hopes and aspirations in these young minds. They also have several insecurities and concerns, and it is indeed the responsibility of the senior pediatric surgeon to lay out a clear path for these young pediatric surgeons. The first concern in the mind of the young pediatric surgeon is regarding their identity. They fear that the specialty pediatric surgery is not popular, and throughout this year, we from IFPs are determined to make noise with the hashtag India needs pediatric surgeons in all forms. We need to promote among the public that the skillful hands of the pediatric surgeon are indeed essential in a child with a surgical problem. Children are not miniature adults. And the surgical problems like pyloric stenosis, intersusception, malrotation, hyperspadias, cloaca, all of them are unique, and this cannot be efficiently treated by an adult surgeon. Like how a pediatrician is needed for the treatment of a medical problem in a child, a pediatric surgeon is also crucial for a surgical problem in a child. We should emphasize this at school camps, news media briefings, social media handles, and also when giving lectures in various forums in IMA or IFP or wherever. The second concern of the new pass out is job. Settling down at the beginning of the career can be challenging, and the regular salary is always while they are settling in the private career. So, creating jobs in pediatric surgery is crucial. And thanks to the efforts of our predecessors like Dr. Dasmir Singh, National Medical Commission has mandated that in every medical college with 100 surgical seats, 10% should be allotted to children. So our Prime Minister also has a goal to create a medical college in every district. So in fact, the theme of this year's Pediatric Surgery Day, which falls on 9th of December, is every district needs a pediatric surgeon. So we have 700 medical colleges in India, but only 100 have pediatric surgery seats. So I request the state unit chairperson to identify the government medical colleges without pediatric post and write to the health minister of respective states to create them. Even better would be to make a personal appointment with the state health minister for creating pediatric surgery post. Health is a state subject, and I request each state chapter to take this issue of job creation seriously. And this is for the future of our young pediatric surgeons. Now, I have two requests for the young pediatric surgeons. We have around 800 districts in India. Half of them don't have pediatric surgeons. The pediatric surgery density in state capitals is too high. We from IAPS are fighting hard to find districts without pediatric surgeons and also create jobs in all districts. So young surgeons should not miss this golden chance to become the alpha pediatric surgeon of that district. By starting in a new area, you may rule several miles with no competition. You also help the children who otherwise need to travel a huge distance in search of a pediatric surgeon. Starting afresh indeed is challenging, but very fulfilling, and it can be very rewarding also. So aid in setting up multiple services like a PICU, NICU, pediatric anesthesia, everything in the process of starting a pediatric surgery career. And wherever a pediatric surgeon has settled in a district, they've always done well financially. My second request to young pediatric surgeon is to remain positive. Avoid any negative comments for the pediatric surgery aspirants. We all together because of the passion and keep helping children with all pediatric surgical problems as much as possible. But at the same time, take help from senior pediatric surgeons whenever you face difficult situations rather than from other specialty surgeons, particularly when dealing with urological and robotic cases. Stay vigilant and don't lose ground. Keep talking in all forums like IAP, IOG, IMA, and spreading the word pediatric surgery. Take a note that you will make pediatric surgery a name that would resonate with everyone and that everyone will value it, the meaning of it by the end of 2022. Long live IAPS. Thank you.
Thank you, sir. I now request Dr. Vikesh Agarwal, sir, National Secretary IAPS, to address the gathering.
A very good morning to all of you. Honorable Vice Chancellor of the University, Dr. Legegowda Aruj, Dr. Kurian, Registrar of the University, my very gracious and very ambitious President, Dr. Ramesh Babu, because he is always like hard hitting with a lot of jobs in the morning to be given to me. I'm trying to catch him up. Very dynamic and very experienced President, past President, Dr. Dasmeet Singh. My very good friend, Narendra Babu, and my dear friends in on the dais and off the dais. So many good friends sitting here. Few of them I'm missing. His speech has actually no value, but it basically it follows the vision of the president. But no association is complete unless you have a great combo like Naren Babu and Subramani. You materialize things on the ground. The vision may be like Naren Babu's, but it's the hard work of the secretary which brings things on the ground. So I congratulate both of them for organizing such a good conference in Tumkur. Everyone goes Bangalore. Too many people ask me in the morning, where are you going? I said, no, I'm going Tumkur. He said, where is it? Sometime Dr. Kurian was saying about this thing. So we need to popularize our region. More and more conferences should be organized at smaller places. One thing I would like to mention here, when I was very young, like in 2005, I cleared my MCA 6, 7. I used to look at the programs of the Karnataka state chapter. When I first organized my conference, I was not very well experienced. First program which I saw was Karnataka chapter program. Chapter is very vibrant for so many years, ma'am. And Dr. Ramesh was very vibrant in making such programs, as far as I remember. And in fact, I copied the ideas from Karnataka chapter. Very few state chapters in India are so vibrant as Karnataka state chapter is. So I again congratulate all of you. More and more people take inspiration from these people. Take this matter forward. Coming to the next thing, I saw the university from outside. I usually lighten myself when he gives me a lot of jobs with other parallel topics and parallel things. So I'm lightening myself with the list of ambitions he has shown today. Definitely, we are serious about that. When I saw the university from outside, as I feel personally, no institution is made just of walls. It's the values which make the institution. One remarkable thing which I saw as I entered the campus was boards of best practices. So that is something we would like to inculcate amongst the undergraduate, postgraduates, right from the beginning, from the inception. So I appreciate that. I will copy that. Thank you. It is best practices can be applied everywhere. Our association has been very vibrant for so many years. This year, like we have done a lot of brainstorm amongst our executive council, how to take it forward. Biggest thing which I find lacking is the involvement of the youngsters. So it's I think it's not the problem of the youngsters. It's basically lack of interventions from the association side, which has not gathered the attention of the youngsters. So we are very sure this year and the coming year, we are planning to have a lot many activities. In fact, we have started recently. We started the next gen mock exam because the exams are nearing. So we started with that. A lot of activities for young pediatric surgeons so that they remain motivated and they don't feel bad about their branch. No branch is bad. It's all about your. I belong to a tier 2 city, and I chose pediatric surgery despite getting all of the branches. I was getting urology also, cardiothoracic, neurosurgery, everything. So by choice, I took pediatric surgery because there was no pediatric surgeon in Jabalpur except Dr. Rana, who was very senior. He was not doing private practice. So I thought that I would do a good private practice there, and in fact, had an opportunity to work with him. Go to peripheral places. Be proud of that. Don't rush to, metro cities. We are making that map of pediatric surgeons of India, and we see a lot of crowding is there in the metro. So it will be challenging to begin in smaller cities, but the growth is exponential and recognition is very fast, and society acknowledges you very quickly. And that is where you can show the progress of pediatric surgery. And pediatric surgery is no more a primitive branch. It is full of newer technologies. All of these experts here, we all started like endoscopic surgery in a day one baby. And one thing more on like a note, our anesthesiologist is here. I always say to my anesthesiologist that 50% of pediatric 50% of all what we are doing, credit goes to anesthesia guy. Because without that, neonatal surgery is not possible. A good neonatal outcome. So it's a good, it will help you out to materialize your cases in the operation theater, and that is truth also. So I strongly believe in that. So I again congratulate all of you for organizing such a good conference. I am Secretary of Indian Association of Pediatric Surgeons, but I'm probably the most accessible secretary. And I'll try to prove that. All of you who would like to be my friend, you're open. Please, you can contact me anytime personally and send your suggestions, ideas. If you want to participate in any of our activity, actually we need people. Involvement of the members. Unless members are involved, there will be no sense of pride. So whatever we are doing, we are planning, is for you. So you need to get involved. So this is my humble request to all of you. Thank you, young ladies here. Thank you, everyone, students sitting in the back. Thank you.
Thank you, sir. I now request Dr. Narendra Babu, sir, Chairman IAPS, Karnataka State Chapter, to address the gathering.
Uh, I thank the organizers for and Subramanya and his team for organizing this scientific conference. And our National President Ramay Babu sir, Vikas Dasmit Singh, all the dignitaries on the stage. I take this opportunity to just wish all the best for the entire team, and also for expanding pediatric surgery beyond metro cities. Like say, we are all thinking about it, and nothing is really happening. In fact, we met our director in the Institute of Child Health, so that now the SNCUs are all there in all district hospitals. Now all the district hospitals have got a pediatric and neonatologist are there. Now this item, Physical also was talking about this in various fora about expanding the pediatric surgery outside the metro cities and all those things. This is the high time. Uh, we made a contact to the government, but nothing happened materially. And now I think since the Subbu and you are already in touch with the government, very close to the government through your chancellor, so I think we can try push some ideas where because there is always government schemes are there. Government schemes are not bad because they give definite income, and those who are there in the district hospitals can utilize that. So because right now in BMC or Indira Gandhi, we have roughly around 6 months waiting list for elective surgery. So that is actually practically mad. No patient is going to wait. So all these patients going to go out somewhere and get operated. The same thing can be utilized in peripheries by utilizing the same thing. So I think as an organization from Karnataka also we should work hard on that. So, otherwise, uh, thank you.
Thank you, sir. I now request Dr. Dasmeet Singh, sir, to say a few words.
Actually, when I finish off my presidency, the most satisfying thing for me being able to hand over to one of my very very good friends and highly capable Ramesh Babu and along with Vikesh Agarwal. So I think they deserve a good round of applause. They're going to take IPS. They've already got the plans in place, taking IPS to the next level. Uh, Getting inspired by Dr. Kurian, I just remembered a story about storytelling. once NASA was having a problem, their space shuttle was just not taking off. So they gave an ad world over that whoever can help us get this space shuttle to take off uh, is most welcome to come and show us the way. So we had this guy going from India. So he said, okay, I don't think you have positioned this correctly. What you do is take this space shuttle. Right now it's vertical. Yeah, uh, tilt it, bring it to a 23.5 degrees angle. Okay, and so they did that, and they say, okay, now you straighten it up again, and then they straighten it again, and then it took off, and it actually worked. So then everybody is asking this guy, come on, man, so what technology have you brought from India? Which IIT? What did you do? He said, nothing. I had a Bajaj scooter. Look at that. Anyway, thank you. I don't think I should be taking any more time. Thank you so much.
Thank you, sir. I now request Dr. Prabhakara sir, Vice Principal, SSMC Tumkur, to say a few words.
Good afternoon, respected dignitaries on the dais and of the dais. Actually, this is a scientific session, so many people they already spoke about the conferences and all. A lot of conferences that happened in our campus. In fact, one of the best hosts uh, and also the best conferences we had in various departments. Uh, First of all, on behalf of the Siddhartha Medical College, I welcome the dignitaries, especially the national chairman and secretary, and the past chairman, and other dignitaries, and also the delegates for this wonderful conference. And I congratulate our pediatric surgery department for conducting this wonderful conference. Thank you. Thank you.
We will now proceed with the felicitation ceremony. I request Dr. Ramesh Babu sir to come on to the I request all the delegates on the dais to felicitate Dr. Ramesh Babu sir, President IAPS.
Collected back.
So you saw the three things. Thank you, sir. We will now felicitate Dr. Vikesh Agarwal, sir, Honorable Secretary IAPS, Level 4 MP. I request all the dignitaries to felicitate, sir. Thank you, sir. We will now felicitate Dr. Narendra Babu, sir, Chairman, IAPS, Karnataka State Chapter. I request all the dignitaries to felicitate. Next, Yatindra sir. Thank you, sir. We will now felicitate Dr. Yatindra and sir. I request all the dignitaries to felicitate. Thank you, sir. We will now felicitate Dr. Linge Gowda, sir, Vice Chancellor Sahe Tumkur. Thank you, sir. I request all the dignitaries to come on to the dais.
This is a video.
Ma'am Subramanian sir.
It's okay. Give it on the desk. Give it on the desk. It's okay. Just give it on the desk.
Yes, sir. Mementos. We now have few mementos for our dignitaries on the dais. I request Subramaniam sir to give it to our Vice Chancellor Linge Gowda sir. A memento to our MZ Korean sir, Registrar Sahe Tumkur. And to our Prabhakar sir, Vice Principal, SSMC Tumkur. Yes. I request Dr. Apurva ma'am to give the memento to Dr. Subramaniam Kattepura sir, Honorable Secretary, IAPS. Yes. We now have the vote of thanks by Dr. Apurva ma'am. Pediatric Surgery, SSMC.
Good morning, all. I extend my warm thanks to Vice Chancellor Linge Gowda sir and Registrar Sir Kurian sir for gracing this occasion. I thank Ramesh Babu sir, Vikesh Agrawal sir, and Dasmit sir for coming all the way with a short notice and gracing this occasion. I thank Prabhakar sir, our backbone for all our conferences. I thank Yatindra sir. I thank all the HODs who are present here, all the delegates, and all the helpers over here. Our event manager, Mana Studios, Shivu, catering, volunteers and students, and my pediatric PGs who have been our backbone. I thank one and all. And sir, sir, sorry. I request Subramania sir to present a memento to Dashmit Singh sir. Sorry. Sir. Thank you, one and all. The program will continue further.
Thank you.
Next person is Dr.
The name Dr. Saravanan also you picked up. Speaker reading you. Saravanan.
Sir, we can.
We will now continue with the session. I request all the dignitaries to be seated. I request all the dignitaries to kindly be seated as we will be proceeding with the session.
The session is going to begin. Please be seated.
Our next talk for the day will be on invasive monitoring by Dr. Prakash Vemgal, sir, Neonatal Perinatal Fellowship Australia, Pediatric Critical Care Fellowship Canada, Director, Rainbow Children's Hospital, Bannerghatta Road, Bengaluru. The chairpersons for this session will be Dr. Kumar, sir, HOD Pediatrics, SSMC, Dr. Raghu SR, sir, Professor and Unit Head, Bangalore Medical College. I request you all to come onto the dais, sir.
Good afternoon. Can you hear me? Okay. Good afternoon. I would like to thank Dr. Subramania for giving me an opportunity to be here today. So the interesting part of it is like, we heard few stories from the secretary too. He said that the outcome of the baby depends not just with the surgeons, not just with the anesthetists, but also I would probably say that we also contribute to some extent. And not only we, the nurses do contribute a lot. So the outcome of a good, successful child going out of the ICU is based on so many factors. It's a teamwork. And once we get all the teamwork in the right place, then we see happy faces around us. So with this, my talk is, the stories, what we heard, is to identify certain important clues and correct those ones at the right time. And how can we do that is by invasive monitoring. And if you don't identify some of those important clues, the surgery may be very successful, but the child might have complications, or we might not save the child. That is the most important thing. With this, I would like to start. My outline of the talk today will be about invasive monitoring. I will not be talking much about non-invasive. When do we do this? What are the advantages? Of course, when you have an advantage and you think that the outcome is going to good, then only you do those invasive procedures. Of course, all invasive procedures are associated with complications. And main discussion will be about hemodynamic monitoring, like the arterial line monitoring, the central venous line, the pulmonary artery line, and the mixed venous saturation, which we draw the blood from the pulmonary artery. What does it mean? A little bit touch about capnography and the intracranial pressure monitoring. Now, this is the typical monitor you see in the ICUs. And any new PG or any person who is not familiar with new parameters here freak out in the ICU, because one of the things, even a saturation monitor, if saturations are low, you get alarms, and any alarm in the ICU is kind of disturbing. And if you think that okay, alarm is one thing which you probably can ignore, no, you can't ignore. So you need to fix those alarms. For what reason? So here in this monitor, you see the heart rate, the saturations, the blood pressure, the invasive blood pressure. You see the CVP, you see the pulmonary artery pressure, you see the ICP, you see the capnography, the end tidal CO2. You have a temperature, you have other derived formulas over there. So this is what typically the intensivist will look into it and act based on his clinical judgment as well as the what we have. Now, why do we need a hemodynamic monitoring? Is because it measures the functional characteristics of the heart, and that is important because what at the end of the day is the perfusion to the tissue and oxygenation. So if you don't have a proper assessment of perfusion to individual cell, then it will lead to cellular hypoxia, and that is not good at all. So it gives a continuous and repeated observation, and for early detection of hemodynamic catastrophes, and hence appropriate therapeutic interventions we can look into it. And of course, we need to have an improved outcome. Now, the most important thing of hemodynamic monitoring is to detect very early low cardiac output failures, and it is very important. And if you don't identify this, you probably end up with problems. How do we do that? By three ways. One is the intra-arterial line, which gives us the systemic pressures; the central venous line, which will give us the right atrial pressures, which will give us the filling pressures; and the pulmonary artery lines, which most of us if unless until you are not working in the cardiac ICU, you probably don't see this. But I'll just mention briefly about it. Now, in the heart, you can put catheters anywhere. If there is a cardiac surgeon, probably he knows how to put this post-op. So if you have a catheter in the pituitary, so you can measure. If you have it in the left atrium, you can measure the left atrial pressure. You can measure the pulmonary arterial pressure, and of course, another one is the aorta, which is the systemic pressure. So this is the CVP, sorry, and the aorta part of it is this part of it, which we can measure through the peripheral arterial line. So you need a transducer to measure all these pressures at different areas. Now, how is the arterial line set up? So it's simple. If you have a peripheral arterial line, you have a cannula placed in, you have a saline filled non-compressible tubing, you have a pressure transducer, and that is connected to the monitor, and you have a pressure pad, which is generally kept so that it automatically pushes the saline around 1 to 2 ml every few minutes so that the line is patent. And usually you set up a pressure which is 10 to 20 times more than the average systemic pressure for that patient. Now, this is physiology, and I think if a lot of us, when we finish our first year of MBBS, we forget about physiology unless until you come back to your critical care training. And physiology is very important because next time when you go to any ICU and if you see an arterial line, if you know what are the components of the arterial line, you probably can tell to the doctor over there or to anyone that there is some problem with this baby's blood pressure. So I'll spend 1 minute over here. So this is the systemic blood pressure. This is the systolic part of it. This is where the left ventricle is ejecting the blood, and then you have this is the systolic part, and then you have the diastolic part. This is the time where the aortic valve opens, and this is the time where the aortic valve closes. Now, if you have any problem with the ejection of the left side, probably you will not see a kind of a normal tracing. So, in the next few slides, I'll come to that. What are the variations? So, it is monitored against the time and the pressure. Common cannulations, what we do is the radial artery. We can use the femoral artery, dorsalis pedis, and very rarely we can use the posterior tibial artery. Now, when we trace this arterial waveform, this is what typically you see. And when you put the catheters any part of the aorta or the brachial artery or the radial artery, you see a different tracing based on the pressure gradients. So commonly we see this, and in cardiac ICUs, probably you will see this if the chest is open, if they have a catheter. We don't put brachial artery because it can cause harm to the arm. And of course, femoral artery, if you don't get the radial artery, use this. So these are the tracing what you see, and that's the same thing that is I described before. Now, these are the variations you would see when you do an arterial line. So this is a normal arterial line tracing. You see the systolic peak and the diastolic part in the aortic valve where it was. You call it as the notch. Okay. So in a normal person, you see the tracing, and when you see this kind of tracing, it is probably overdamped. So you see here the diastolic pattern is normal, but the systolic component is come down. So generally you see this when there is a clot or a fibrin sitting or something is kinking. And this is under damped tracing. And if you see a very peak systolic as well as the diastolic component, then it is probably under clamped, under damped. Then this is generally seen when you kind of have the kinking in the circuit, especially the cannula or the catheters which are inserted. Again, it's the same diagram which has been shown here. This is a normal flush. When you flush the arterial line, you get this square window. Then it has to come back to the normal tracing. If you don't, and if you see oscillation, then it is under damping. If you see a kind of one or a brief, damping, then it is over damping. Now, arterial pressures are helpful in diagnosing hypovolemia, where you see a blunted diprotic notch, determining the severity of cardiac dysarrhythmias, especially if you see alternance, pulsus alternans, you see in the tracing, and also for evaluating, in some cases where you have cardiac tamponade, you get pulsus alternans. So it not only gives the blood pressure, you probably can follow what are the arterial tracing which is happening in the cardiac activity. Now, what is more advantage in having intra-arterial line is measure the mean arterial blood pressure. So if you're in the ICU, you probably don't chase the systemic pressures and the diastolic pressures. We probably look at the mean arterial pressure because that is the one which gives us what is the blood going to the tissue level. So that is one thing which you always have to keep in mind, what is the mean arterial pressure you are not targeting. And also when you have this arterial line, it gives you a rapid movement to movement changes. And of course, when you have an arterial line, you have to do the blood gases easily available and you can do it within 1 or 2 minutes. And when you see some of these hemodynamic changes, you probably have to decide what are the vasoactive medications you need to use, especially in hypertension. So you need to decide based on your clinical examination as well as your blood pressure monitoring. And there are a lot of formulas which we can derive based on echo as well as intraarterial as well as the blood gas sampling. One of them is the systolic pressure variations you can measure, and also you can derive at the stroke volume. Now, where do you place the transducer? It is placed at the fourth intercostal space in the mid-clavicle line at the level of the right atrium or the left atrium. And we always have to zero that to the atmospheric pressure. So then only you get the calibrations right. Now, this is what you typically see in our ICUs. You have a ventilator, you have a ventilator circuit. You can see this a capnography instrument which is being attached to the endotracheal. You see the central lines placed, and you can also see the arterial line which is zero at the level of the right atrium. This is the transducer which is connected to the cardiac monitor. And this is of course a echocardiac machine. Now, variations in IABP, because of the level, you are not kept at the level of the transducer, it can vary. And if the arterial pressure measurement will be most accurate as long as you have a proper catheter which is in place and also the transducer which is properly set up. If the tubing is too long, or if it is too short, or if it is very soft and pliable, then there is inaccuracy of measurement. So you need to have a standard of what you place in your ICU. So as I told you earlier, the mean arterial pressure is the most important parameter which as an intensivist we'll be looking at it because it decides about the driving force for the peripheral blood flow. And also it doesn't have a waveform and that doesn't change whenever there is any change in systemic as well as systolic as well as the diastolic blood pressure. So if your mean arterial blood pressure is good, that means your blood flow to the tissue level is quite good. Now, how can we measure that? It can be measured, but most of us, when we have an invasive monitor, it is electronically measured. And if you want to calculate that, it is one third of the pulse pressure and plus the estimated diastolic pressure. That is what it is. But if you look at the heart rate of 60, it gives you the accurate value. But if the heart rate is very high, like in babies, it can be falsely calculated. So now this systolic pressure variation, there is little bit of IMM of up and down. You probably can diagnose the hypovolemic state, especially in hypovolemia, a variation in the graph of this probably will depict that, okay, of course, if it is more than 15, definitely it is hypovolemia. Probably your baby requires some volume administration. Now, the complications, whenever there is any invasive thing which we do, always carries a complication. One is arterial thrombosis. It can has, probably a vascular spasm, and the whole part of the arm can go into kind of ischemia. And probably you have to notice the fingertips if it is a radial artery, and make sure that the perfusion for all the digits are well maintained. And of course, it very rarely you can see arterial trace, pseudoaneurysm, and arteriovenous fistula formation. Now, coming to the right, heart pressure or the right atrial pressure monitoring, which is commonly, done again in the ICU. So most of the time nowadays, because we have echocardiography, we don't really need to look into the filling pressures. It is more for IV access or the central access, and of course, it measures the right atrial pressure, and it also assesses the right ventricular function. And if the catheter is in the right atrium, probably we can follow the trend of mixed venous saturations in these babies. So it can give lot volumes of fluid into these babies, especially if you have a central line. And of course, we can give hypertonic salines and solutions like calcium, potassium, and glucose in an unstable baby. Now, what are the sites we use? We use internal jugular, subclavian, and femoral. And normal CVP is depicted over here. It is just basically in tracing with the ECG. You can see this is the systolic part of it. You have a C, and V component, and the diastolic component over here. Now, elevated CVPs can be for various reasons. Of course, it is usually to the right side of the heart lesions where you see a right pressure, the right atrial pressure going up, and you probably can identify those things. And normal atrial 7 milligram mm of Hg. And of course, the central venous lines measure the preload. If there is a decrease in the CVP, you need to give volume. And of course, we can also give medications. But if there is a rise in CVP, probably your volume overloaded, probably you need to think how can you cut down on the volume. And as I told you earlier, we also measure mixed venous saturation, but the ideal place is the pulmonary artery. Of course, complications is extravasation of the fluids into various compartments, kinking, thrombosis, sepsis, which is quite nasty if you get into it. And of course, you need a great care in management. And obviously, when you are inserting, you make sure that this is done in a septic precaution way, and proper hand hygiene is important. And always use a three-way connectors to all these lines so that you don't have any issues in terms of administration. So the mixed venous saturation definitely helps in seeing the trend whether the child is kind of extracting more oxygen in terms of delivery of the oxygen. So you need to see the trend, and that will give us whether this child is getting better or worse. Now, this is the pulmonary artery catheter, how it looks. It's a long catheter, and this is how it is being introduced to the pulmonary artery. At the end, you can measure the pulmonary wedge capillary pressure. If this is the marking, you probably can assess the right atrial pressure, right ventricular pressure, and of course, the pulmonary artery pressure. These are the tracing of different areas. And if you see, the wedge shape is what the tracing is. Now, the cardiac output is measured by, basically the echo. Of course, this is important tool for us. Even if you have invasive, probably have to get the cardiac echo done in terms of functionality. Just a quick one or two slides. Is it okay? Yeah. Capnography is a measure of carbon dioxide exhale, and it's basically used to see whether the is inside by doing using a calorimetric testing or by measuring quantitatively how much it is by infrared spectrometry. So this is how the capnography or calorimetry test. So if the endotracheal tube is intubated, if it turns to purple, then tan to yellow, it's almost sure that you are in the endotracheal tube. And if there is no color change, then probably your tube is not in the trachea. And probably other thing which can happen is if there is a cardiac arrest, there is no pulmonary blood flow, that also doesn't reflect over there. And infrared capnography is a measure of carbon dioxide in the endotracheal tube when the patient is exhaling. And this is how we connect all the connectors. And you see this tracing on the monitor. This is the end tidal CO2. And these are the photo detectors and the transmitter which is connected over here and connected to the patient end. And there are various, as the patient breathes, usually you don't see much CO2. At alveolar ventilation, you'll see more coming out and then plateaus. And this is again the inspiration part of it. Now we always measure and compare arterial CO2 to intestinal CO2. The difference is around 3. And if the difference is more than that, you think about all these conditions: lung disease, excessive lung inflammation, low cardiac output, and pulmonary embolism. So it gives a lot of information what is happening in terms of ventilation as well as the cardiac output status. Now, this is a graph which shows that if the cardiac output is low, your end-tidal CO2 is low. As your cardiac output improves, your end-tidal CO2 also improves, which reflects in the arterial blood gas. There's a nice correlation with that. So coming to the last 2 slides is cranial pressure monitoring. And of course, we all want to make sure the cerebral perfusion pressure is quite good. And to have the cerebral perfusion, you should have a mean arterial pressure. We calculate and minus the intracranial pressure. Where all we can insert the ICP. One is dural, which is called Richmond board. The one is the intraparenchymal. The one is the ventriculostomy, and the ventricular transducer, where you can probably measure the ventricular pressures. And when you look at that pressure, it has 3 curves. So initial state is a good compensatory reserve. Then there is a poor compensation as the intracranial pressure rises, and then there is a deregulate vascular reactivity, which can happen in very raised ICP. And we have a good autoregulation up to some threshold. But in a child who has an very raised ICP, it doesn't go in this fashion what is normal usual. Kind of a steep increase in ICP within few hours to few minutes. So these are the various conditions which you can get a raised ICP, and these are the indications where you do the ICP monitoring is the normal range for different age groups. And this is the typical tracing you see. This is the wave. So you can see the patient's ICP is quite okay. As for some reason, ICP starts rising and it plateaus off there and it again drops. Again, you feel few oscillations. Small rise in ICP. Of course, any large rise in ICP is notorious. Probably you are landing up in brain herniation. You need to think what we need to do at that stage. So with that, I think I will end my talk. I'm sure there are a lot of other invasive things which I would love to discuss, but I was given only 15 minutes. They thought that I'm an intensivist. I should decide all this, take this decision within few minutes for the better outcome of the child. So with that, I will end my talk.
Thank you, sir. The next talk will be on blood and blood products in children by Dr. Intizar Mehdi, Director and Head, Department of Pediatric Oncology, Hematology and Bone Marrow Transplant, HCG.
Next slide here only. Thank you. At the outset, I would like to thank Dr. Subramania and his team for giving me this opportunity, and I would like to congratulate your team for putting up this wonderful conference. It's already been great, and I'm sure it's going to be great in the next couple of days. When I was actually given this topic, I was thinking whether I am the right person to be speaking on this. I deal more with hematology and oncological financial problems. And as we all know that nowadays there is MD in transfusion medicine and immunohematology, and most of the bigger centers have transfusion experts. Majority of the time, they are the ones given this talk. But then, to be frank with you, even though being in this field for almost close to 20 years, when I was making this talk, it was a learning curve for me also. So I am sure it's going to be beneficial for my colleagues here and especially for the uh, undergraduates and postgraduates and specialists in specialty training. So, management of blood and blood products is integral in the management of children, and it's a life-saving procedure. Lots of medical and surgical fields, cardiac surgery, neurosurgery, orthopedic trauma, neonatal, PICU, and of course, in my domain, for example, in hematology oncology practice, in bone marrow transplant setting, it comes in so many ways. It is going to be beneficial. Now, about few years ago, we all knew that there is whole blood and then there is packed red blood cells. And now, of late, as we all know, there are platelets, but there are different types of platelets. There is FFP, cryo. That has also been there for some time, but there are a lot of modifications. Now we have concentrates and we have factor available also. So, so ABO blood grouping system, we all know Carl Landsteiner, and he was given the Nobel Prize in 1930. And basically, we have the ABO blood grouping system, but now we also have RS, Lewis, Hill, and Duffy. And we all know this how the blood groups are coined A, B, AB, and O based on the antigen they represent. And I'll take a minute on this slide how the actual whole blood is separated into its components. It's important to have a working knowledge of this. So when you spin the whole blood at centrifuge at 2000 revolutions per minute for 2 minutes, it will get separated into platelet-rich plasma and packed blood cells. Packed red blood cells are separated, and platelet-rich plasma again you do a hard spin centrifuge at 5000 RPM for 2 minutes, get separated to platelets and platelet-poor plasma. And this platelet-poor plasma, when it is actually frozen at minus 18, it becomes FFP. And when that is allowed to thaw for 24 hours, it becomes cryoprecipitate. So that's how all the components actually come. So let's talk about PRBCs as it is commonly called as PRBC and some centers call it as PRC, estimated unit size. We all know 250 to 350 ml, and hematocrit of the unit is usually 65 to 75%. Remember that it's a packed red cells, so it's quite concentrated. And the preservatives either it will be CPDA1 or one. And the volume of PRBC depends on the clinical situation really. The child, what is the condition you are treating, what is the comorbidity. So the usual requirement volume will be 10 to 20 ml per kg. That's the simple formula how to calculate how much of rice you want. Let us say the hemoglobin is 6 and the weight is 15. Then if you multiply it by 3.5, then it will become 315 ml. So in simple terms, for a 15 kg child, about 20 ml per kg, that would be the maximum volume. And how it should be infused? It should be infused in 3 to 4 hours. Infusion rate should be 2.5 ml to 5 ml per kg per hour. Avoid circulatory overload. And if the patient is already having cardiovascular instability, then probably slower or lesser volume and may need diuretics. What are the modifications? Many times, the blood bank officer will call you and ask, do you need a leukodepleted WBC filtered? So, what is the purpose of this WBC filtration? Earlier, it used to be by bedside filter. Now, it can be done in the blood bank. It removes about 99.9%. So, what are the adverse effects which are prevented because of this febrile non-infectious transfusion reaction? But more importantly, HLA alloimmunization. For example, for some children like thalassemia who require continuous transfusion and transfusion associated disease like CMV, and most important thing is the transfusion associated GVHD. But remember that 99.9% efficacy of leukodepletion is not good enough. Irradiation, it removes almost completely the WBCs from there because something like THUHD, which is extremely rare complication following transfusion of blood products, is uniformly fatal. So we have to prevent that. So where do we need irradiated packed red cells? Majority of the time it is in the hematological or oncological setting during bone marrow transplant, solid organ transplant, intrauterine transfusion, or sometimes children who are suspected or proven to have immunodeficiency, especially cell mediated. Platelet component. So if you get the platelet unit just from the routine separation of the blood, that is the usual platelet unit. There you have about 5.5 into 10 to the power of 10 platelets. Random donor platelets, where multiple donors' platelets are pooled, and there the platelet number is much better. Apheresis platelets, that's the norm these days, majority of the ICU settings and majority of the hematological oncological settings. So there the platelet number is much higher and you get more incremental. And what would be the indication of platelet transfusion? Essentially, there is a problem with the number, which could be because of production or destruction, or it could be because of platelet dysfunction. For example, Glenn thrombocythemia, Bernard Collier, or some other. When to transfuse? Again, it will depend on the condition of the child, what you are treating for. For example, in ITP, you would never transfuse platelets unless there is a bleeding. Whereas if the situation is like fetal lymphoid malignancies, maybe 20 is the cutoff, solid tumors 30 is the cutoff, for procedures 50 is the cutoff, for major surgeries 75 lakh to 75,000 to 1 lakh. Now, what will be the dosages? For example, SDP 10 ml per kg, volume is usually around 200 to 250 ml. RDP 1 unit every 5 kilos. So if the child is 20 kilos, I would transfer 4, but the maximum is 6 units. Remember that platelets are usually transfused at a faster rate compared to PRP. Children will tolerate pretty well. So if you have 4 bags, they just finish within 1 hour. If the child is very small, then you can limit it at 10 ml per kg per hour. FFP, usually the volume is 200 to 250 ml, prepared from single unit of whole blood, usually freezed and kept at -18 to -30. Shelf life is 1 year. What is important, contain all the coagulation factors and proteins, but factors are not concentrated here. So where do we need FFP? Majority of the time in patients having liver disease, DIC, massive transfusions following polytrauma or something like that. If the patients are taking warfarin and then you have a very high INR, or if they are having bleeding or they are going for an invasive procedure, major surgeries, children having TTP, for example, due to various conditions, therapeutic or exchange transfusion at that time, and rarely in patients with coagulation factor deficiency. If you don't have the factor available, then probably you'll use FFP. Always remember, FFP should not be used in centers where factors are available because factors are not concentrated. But in emergency, it can be used, and it should not be used as a source of albumin, for example. What is the dosing of FFP? 10 to 50 ml per kg of FFP. And usually, this dose is good enough to bring the factor levels to 25 to 30. And remember that if the factor level is around 25 to 30%, for example, factor 8 or factor 9, that is more than enough. Patient is not going to have any significant bleeding at that level. If the FFP is thawed at 4 degrees, then a precipitate remains. That is called as the cryo. And cryo is actually very rich in fibrinogen and factor 13, and a bit of factor 8 and 9 also. Von Willebrand factor is also there, but more in fresh frozen plasma. So where do we give cryo? Mainly in fibrinogen deficiency, factor 30 deficiency. And if you don't have ability for FFP availability, then as a second line in factor 8, 9 or 1 milligram disease. What are the contraindications? Definitely, if there is no hemostatic effect, don't use it. And don't use it DIC. It's not going to help because it does not contain all the factors. Those hypofibrinogemia 0.2 into weight and factor 13 deficiency 1 bag for every 10 kgs. So only once. Bleeding in one millibrand, probably you'll have to repeat it every 6 hours, again 1 bag for every 10 kilos. Now, again, is a blood group matching required for all blood products? So PRBC is yes, platelet preferred. Always better to have same blood group platelets. Don't have, it's not required. FFP and cryo, definitely it's not required. Now, what are the adverse reactions we may come across, and what should be done if you notice a reaction? So reaction can range from very simple, like febrile, non-hemolytic reaction, to simple allergic reaction. What is important is stop the blood transfusion immediately. Inform the treating consultant. Inform if you have a blood bank officer, please inform them at the same time. Then decide what you are going to investigate. So, like I heard Dr. Lalita's talk, and Prakash Vemgal sir is here. We always remember that whenever you have a problem at hand, what is important is assess how serious is the problem. ABC. Please remember ABC. Even a blood transfusion associated reaction goal is to rule out fatal reactions. What is the kind of reaction the patient is having? Is it anaphylaxis? Is it a simple allergic reaction? Is it Raleigh, taco? Just learn about this in the next few minutes. And then the transfusion should be stopped. Give the emergency medication. Send the blood product back to the blood bank and also send a sample of the patient and also the urine sample. So these are all the common symptoms which we all encounter in our practice during transfusion: fever, chills, rigors, rashes, itching, pruritus. Sometimes more serious abdominal pain, flank pain, hematuria, change in color of urine. Sometimes we can start having bleeding, oliguria, and then signs of anaphylaxis, conjunctival edema, periorbital edema, or edema of the lips. These are all emergency situations. So we have to identify these children who are going to have severe reactions. There is hypotension, for example, drop in the blood pressure, what has to be done? So, what is a mild reaction? Mild to moderate allergic reactions transmission can be restarted once the symptoms have subsided. For example, mild allergy or mild, just rashes, and the patient is comfortable. The reaction form will go to the blood bank and just follow the detailed workup. So, as you can see, it's a busy slide. I'm not going to go through all that, but you can see that there are so many known complications with, transfusion. Charcoal, which is transferred to circulatory overload; Raleigh, which is the acute lung injury; allergic reactions, anaphylaxis, febrile, non-hemolytic transfusion reactions, and acute hemolytic transfusion reaction, and of course, infections. Allergic transfusion reaction probably the commonest, as because the allergen present in the donor plasma, and usually it's mild, and with antihistaminics it is going to settle. If the patient has more than two reactions of this type, especially for children with thalassemia, they are going to be on regular transfusion, probably pre-medicate them with the antihistamine. Febrile non-hemolytic transfusion reaction, for example, is because the antibodies against the leukocytes or platelets in the donor blood component, and they usually have high-grade fever, chills, and these patients require pre-medication with paracetamol, and you can pre-medicate in the subsequent day. Hemolytic transfusion reaction, as you can see, the differential can be, ranging from acute autoimmune hemolysis to, patients having underlying immunohemolysis or G6PD deficiency or infection associated. But that's an emergency. Patient will have precipitous drop in blood pressure. They will have usually change in color of urine. They may develop jaundice, and they need to be stabilized. And you have to stop the transfusion and try to, give them correction with hydration and diuresis, and support them based on the situation what is required, and get help from your ICU colleague. If you have somebody like Dr. Prakash in your unit, then there is no need to worry. He will support you during that time. Anaphylactic reaction can happen. Recipient antibodies to soluble substance in the donor plasma. Probably this is one thing which we as doctors can never miss and never miss. And please remember that patients who are having IgA deficiency, and if they are given transfusion because of the IgA present in the blood, they can have the first time anaphylaxis and it can be fatal. So please believe that every transfusion that you are going to give can be dangerous. So be prepared for the worst scenario, even for a simple PRBC or any blood product transfusion. So we all know the signs and symptoms of anaphylaxis, and it has been covered by other various different topics. What is again ABC, adrenaline, hydrocortisone, probably some anti has to be given, volume and all those things. Circulatory overload, please remember patients who are having pre-existing cardiac problems or patients using CCF or some other situation there, you have to limit the amount of blood product that you are going to administer. Take the help of your fellow colleague, ICU colleague. Probably you have to give it over a longer period of time, probably diuretics in between if the transfusion is really required. What about Trali? Again, a very dreaded complication following transfusion, nothing but acute lung injury. Usually acute onset hypoxemia, respiratory distress, drop in SAT, and this should happen in the where you have ruled out other causes of acute lung injury, especially not having any pneumonia or any pre-existing illness majority of the time. Citrate toxicity can happen. For example, excessive infusion of citrate during massive or rapid transfusion. Typically, this happens when patient is being treated for polytrauma or some kind of major surgery where you transfuse lots of blood. So more than 3 to 4 units of PRBCs. That's the time. They can present tetany-like features. Patient has to be given calcium gluconate for correction, and if they don't respond, also consider hypomagnesemia. Like you manage majority of the time calcium toxicity. In hypothermia, I mean, we sometimes take it very light. The blood which is coming from the blood bank, blood product is going to be quite cold. It has to be brought to the room temperature before transfusing. If you transfuse in the same situation, patient can have very dangerous hypothermia. Can be very, very dangerous. So please remember to bring it to the room temperature before transfusing. As I mentioned, TA GVHD, especially in the first year after I started practicing pediatric hematology oncology 15 years ago, I saw a 2-month-old child from one of the institutions where I am trained actually. and the child was transfused PRBC in the NICU setting because of a definite indication. And the child was referred to me subsequently, and child had transfusion associated GVHD, extensive skin rash, multi-organ involvement, and uniformly fatal. So then the question, should you give irradiated blood products to all children? It's probably not practically feasible, but when available or when you are suspecting any kind of immune deficiency, those children definitely yes. For others, if you at least do leukodepletion, it's better because leukodepletion 99.9% of the time it will protect. Irradiation will not be available outside the oncological setting. Infectious agents, we all know gram positive, gram negative sepsis can be there, bacteria present there, or sometimes contaminant, and they may present very badly. We all know the window period, HIV, hepatitis B, HCV, malaria, and so many other viruses can be transmitted by this. So, last 2 minutes I am going to spend just on the summary. Please remember, packed red cells 10 to 20 ml per kg, that's the formula. Platelets again 10 to 20 ml per kg, usual maximum STP 1 unit, FFP 10 to 15 ml per kg, and storage, we should have a working knowledge of storage. Packed cells are usually stored at 6, platelets 20 to 24, and FFP and cryo are stored at -18. And the dosage of blood components we discussed. Remember this formula PRBC children 4 ml per kg will raise hemoglobin by 1 gram. That will give you how much volume you want to transfuse. RDP usually 1 unit platelet will raise by 7 to 10,000. Calculate the number of units based on that. FFP 10 to 50 ml per kg. Cryo again 1 bag for every 10 kilos. Small children below 20 kilos. Simple. If you remember at least this much, 10 to 15 ml per kg. That's what you are going to give. Again, the cutoff for PRBC will depend on what condition you're treating. For example, in somebody with autoimmune hemolytic anemia, you would not transfuse unless the child is hemoglobin is 5 or hemodynamically unstable. In somebody like THAL, you would transfuse at a pre-transfusion hemoglobin of 10. If somebody is like on chemotherapy, like for us, we would transfuse at cutoff of 8 or 7, something like that. So it will depend on so many other factors, morbidity, and what are the patient is having, what's the situation. Platelets, I mentioned, there might be a situation of ITP, 10,000 platelets, we don't transfuse. Then there may be a situation of 50,000, 70,000 platelets to have major, neurosurgery, for example, we need to transfuse. So it all depends on what the underlying condition we are dealing with. FFP, non-bleeding stable patient, please do not correct the labs. Don't look at the INR and PDT and just give FFP. Only if the PDT is significantly prolonged, patient is going to have a major surgery. Definitely, if there is bleeding, we would transfuse. Lastly, about cryoprecipitate, again, bleeding surgery, fibrinogen. This is a very important thing. Non-bleeding fibrinogen less than 100, they are still at risk of bleeding. So please give 1 dose of cryo. Bleeding surgery patient below 100, maybe more than 1. So this is one line while I was preparing for the talk, I came across a list of why the blood transfusion is a necessary evil. A very difficult statement to understand in the beginning for me, and I thought we are being questioned as to why we are doing this. But then I understood. See, as you know that during transfusion you can have a mild allergic reaction to something severe as anaphylactic reaction. It could be fatal. Or the patient may have Trali, taco, or patient may have a THGVHD, which could be life threatening. And being a biological product, there is always the risk of so many infections. So please remember that use blood products very sparingly, required for treating definite indications are there. And this line I have highlighted, we all know that blood is an organ. Blood is not just a fluid. So blood transfusions are equal to organ transplantation. Sometimes a single unit of transfusion in their life can be life-saving, can be a problem also. So please question yourself what is the definite indication of that particular product transfusion before ordering for it. And please remember that writing the blood request form is primary responsibility of the main doctor. It's not just, and it has to be cross-checked by 2 people. And once the blood product is there, make sure that the labeling, everything. These are all simple things which will go a long way in preventing some of the dreadful and preventable side effects. And I bring greetings from my unit in HCG, our unit where we do our little bit of pediatric hemonc unit. I've been there for almost 13 years. We do benign hematology, hemato-oncology, solid tumors, and bone marrow transplant. And my colleague, my close friend, Dr. Babu, has also been helping me in many cases in my center. And we have a training and fellowship program for people who have finished their pediatric training MD, it's for 1 year in-house fellowship or 2 years RGH. And we do a lot of collaborative work, post papers and posters and clinical trials. And that's my beautiful team. Great to them for picking up this, helping me out in managing these small kids with children with cancer and blood disorders. Thank you. If there are any questions, I'll be happy to take.
Thank you, sir. The session is now open for discussions.
We had a nice session both on invasive monitoring by Prakash sir and blood and blood products by sir. And if any audience have any questions now, they can ask.
I think we made everyone clear. Or they haven't understood.
Or probably if we are close to some time, I guess. Just a comment.
Both of them being necessary evils. And you need to understand exactly how to apply it and to take how much to take from it. I think both are understood very well. We do a lot of hemato-oncologists always there in the anesthesia team. We do have a lot of problems where we try to follow the guidelines. Same with the invasive monitoring also. But I think very well brought out the two very essential but necessary evils. If you understand the evil and use it properly, it makes a big difference to all.
Yeah, one point at this point of time is when we were trying. I used to see anesthetists and the surgeons carrying the blood along to the theater. Now, of course, it is there, but I don't see that as one of the important things. Mainly because the surgeons are doing wonderful job, blood test surgery or very less, bleeding. And of course, we as an intensivist, when we are transferring the baby to the theater, we make sure there is a checklist. What is the hemoglobin? What is the latest electrolyte? What is the blood gas? What is the temperature? And we hand the baby, in such a state that is so stable. And of course, the anesthetics colleague will make sure that that baby is maintained in that state because we have all the monitors connected. And when we receive the baby, we cross check everything is fine. So that way, there's so much checks, and that gives the good outcome of the babies, I feel.
What is the role of invasive monitoring congenital diaphragmatic hernia?
Definitely, congenital diaphragmia is a big challenge, especially if there is pulmonary hypertension. And of course, you need an intra-arterial line to monitor the blood gases as well as the blood pressures. And it is great if you have the pulmonary artery catheter. But if you look at the post cardiac surgery cases, let's say a child who had a VSD, cardiac surgeons put in a pulmonary artery catheter to monitor the pulmonary arterial pressure. But if it is a straightforward congenital diaphragm hernia, which sometimes we do get it, generally you just require the arterial line to monitor pressures, blood pressures to keep it suprasystemic. And of course, you need echocardiography to see what the pulmonary artery pressure if you don't have the pulmonary catheter. And it depends on when was the insult happened and how bad is the pulmonary hypoplasia and what is the outcome. But if you look at the data over the years, which people have looked into, a child who had a very bad pulmonary hypertension, his lungs are not well developed, probably they are the bad outcomes. So 50% to 60% is the mortality rate if you have a diaphragmatic hernia, unless until if it's just later part of the gestation, which you have noticed. And I think Rajat has a presentation later. I don't want to see his presentation and talk about that. So yeah, you have another question.
Non-invasive is good enough for CDH. You want really
Non-invasive in terms
monitoring
of
is good enough for CDH. Why do you need invasive monitor?
Invasive monitor, it's only, we don't put a pulmonary arterial catheter for diaphragmatic hernia because it requires, special skills to put in the catheter into the pulmonary artery, and of course, it has a lot of complications. But the post-cardiac surgery babies, there the pulmonary hypertension is quite high. In order to titrate the medications, then they put it over there. But if you ask me, diaphragmatic hernia, it's only echocardiography is good enough. And if you need a arterial line to monitor the blood pressure, as well as to do the blood sampling, because you don't need to, probably may have to do so many blood sampling for this baby for the first couple of days. That's why you need arterial line. Otherwise, you don't need anything else.
Thank you.
Thank you, sir. We now request the chairpersons to felicitate our speakers. Dr. Prakash Vengal, sir. Dr. Intizar Mehdi, sir. We now request our speakers to felicitate our chairpersons. Dr. Kumar, sir. Dr. Raghu SR, sir. We will all now disperse for lunch. Kindly be back by 2:15. We will start the next session sharply at 2:15. Thank you. For after lunch, who will be the chairperson? Leading donate will be.
ಅಲ್ಲಿ ಇದೇನೋ ಬಂದ್ಬಿಟ್ಟಿದೆ ಆಯ್ತಾ ಕ್ಲೋಸ್ ಒಂದು ಟ್ಯಾಬ್ ಬಂತಲ್ಲ ಮಂಜುನಾಥ್ ಸರ್
Good afternoon, everyone. I request everybody to kindly settle down. Go ahead with our session. The next session for the day is on urinary tract infection. Medical talk will be given by Dr. Aparna Iyengar, ma'am, Professor, Pediatric Nephrology, St. John's Medical College. The chairpersons for this session will be Dr. Anand sir, Professor and Unit Chief, Pediatrics, SSMC, and Dr. Deepthi ma'am, Professor and HOD, Dean of Research Wing, AIMS, Mangalagiri. I request the chairpersons to come onto the dais, please.
Good afternoon. It's always a special invite when it comes from surgeons to the medical clinicians and especially from the surgical society. So thank you very much, Dr. Subramania and team, for having us here. Another reason that I'm happy I'm here is that I was looking forward to uh, meeting Dr. Pooja, who has recently graduated her one-year fellowship in pediatric nephrology and has joined SSMC. So this institution is supporting her, and it's very nice to see that. UTI is a evergreen, hot topic, and the best way to handle it is to always have a jugalbandi between the physicians and the surgeons. And I think I should congratulate the scientific committee for giving this kind of a format of having the medical and the surgical aspects being discussed back to back. So, if you would ask me, am I still worried about UTI? Is there a concern? I would say definitely a big yes, because we still see many of these kids coming to us quite late. You can see a child here with severe failure to thrive, recurrent UTI, secondary to obstruction. As surgeons, you can see the vesicostomy opening, and this child is so sick in the ICU with a lot of fluid electrolyte imbalance and abnormal renal function. We still do see kids who come in a stage like this, wherein the catheter was inserted in this boy for last 3 weeks, and he's been going from doctor to doctor. Why? Because he had UTI and then he had low urinary tract symptoms, and there was incontinence. So the best way was to just insert the catheter and say, okay, the incontinence is not going to be there, and you come after 2 to 3 weeks. This kid had this finding, right? Nobody had even observed this. So it was undetected till we just completed a spine and genital examination. So you would all recognize where this recurrent UTI and LUTD symptoms come from. Unfortunately, we still see many kids come in late stages of CKD, that is kidney failure of end-stage kidney disease. And the starting point would be recurrent UTI, it could be obstructive, it could be non-obstructive, and um, we would see a child coming to the emergency like this. You can see uremia and metabolic acidosis, symptomatic like it's too late because the child is already in end-stage kidney failure. So, are we going to say anything new? I'm sure as surgeons, all of you know how important it is to detect UTI. That's not what we are discussing here today. But let me tell you that many pediatricians still are not confident, are not competent enough to diagnose, to give prompt therapy, and to refer time. This is the latest guidelines from the Indian Society of Pediatric Nephrology on UTI, and today's talk will be based on this guideline. I would now like to invite one of our very sincere and hardworking DM resident in pediatric nephrology, final year DM resident, Dr. Mohammed Bilal, who is originally from Hubli. And as we were discussing in the morning, it's nice that many of these pediatricians come for super specialties and go back to their um, original districts to care for children with kidney disease. So Dr. Bilal is going to be one of them, and he's going to take you through this topic through 8 key questions. Bilal, please come.
Good afternoon, everybody. I will be dealing about the new updated guidelines, evidence-based clinical practice guidelines mainly for the urinary tract infection and primary vesicular reflex. We'll see how delay in diagnosis of a urinary tract infection lands up into a severe disaster. We have a patient who has presented at the age of 3 years with history of having a recurrent dribbling of the urine and recurrent urinary tract infection. At the age of 6 years, he was been diagnosed as posterior urethral valve and he has underwent a perforation. At the age of 10 years, he has progressed to chronic kidney disease and he has presented to us at the age of 12 years with renal replacement therapy in the form of continuous ambulatory peritoneal dialysis at the age of 12 years. And in this year, that is the age of 16 years, he has underwent a renal transplantation. So we can see that how a delay in diagnosis of UTI who has landed up to a severe disaster that is ASKD, for which he needs a renal transplantation. Now we will be dealing with how to diagnose an UTI. I have some few questions. Who your questions will be who is at the risk for the urinary tract infection? Then second, how to screen for a UTI in a clinic? How to confirm a urinary tract infection? What tests are indicated to evaluate a urinary tract infection? How to treat and prevent an urinary tract infection? When is antibiotic prophylaxis to be indicated in a UTI? How to manage a recurrent UTI? When to refer a pediatric nephrologist or a urologist? Why should one should treat a UTI very much urgently? Who is at the risk for UTI? We commonly see having an underlying congenital anomaly of urinary tract, who has a urinary tract obstruction, who has vesicoureteric reflex, a neurogenic bladder, and a bowel bladder dysfunction, and nephrology. The most common who has this, which is most common prevalence of a recurrent UTI is mainly the vesicoureteric reflex and bowel bladder dysfunction. There are certain terminologies which has been updated. When do you say is a significant bacteriuria? Colony count is more than 10 raised to 4, 10 raised to 4 to 5 per ml of a single species in a midstream clean catch in a well-trained children. When it is said to be an asymptomatic bacteriuria, that is presence of significant bacteriuria, one or two specimens in a child with no any other symptom. Recurrent UTI, who have second episode of attack of UTI. It's a complicated UTI. Presence of fever, toxicity, persistent vomiting, dehydration, and renal angle tenderness. Simple UTI, it is more of cystitis phase. Low grade fever, dysuria, frequency. How do you screen for a urinary tract infection in an OPD? If you have a report of a urine routine, does anybody say is it a UTI? what usually we as a screening test for a UTI, we usually see leukocyte esterase, in which in this it is a moderate, and next is a leukocyte nitrate, which is a negative, and then we have to look for the pyuria. Uh, in this, it is only 2 to 5 cells, and many of them will be diverted by the presence of bacteria in the urine that is present as +2. So we invariably will consider this as an UTI, but it is not an UTI. Then we'll send a urine culture. This urine culture which has been sent, which was suggested of having an unusual organism that is Klebsiella pneumonia with a colony count of less than 10 raised to 4. So is this a UTI? Still, it is not an UTI. Then how do you screen for a UTI? Basically, in a OPD, within a short duration, you have to diagnose an UTI. The basic screening test to be done in a urinary tract infection is mainly you can do a urine microscopy. In a urine microscopy, you have to look for the leukocytes. If it is an uncentrifuged sample, it should be more than 10 or equal to 10 leukocytes. If it is a centrifuge sample, it is more than or equal to 5 leukocytes, which has a very good specificity if it is present. The other screening test which can be done is leukocyte esterase and leukocyte nitrate, which has a good specificity and moderate of sensitivity. If both are present, both leukocyte esterase and nitrates are positive, you have a high specificity and low sensitivity. This will help us to diagnose early and treat the urinary tract infection. What are the pointers to diagnose the UTI which has increased risk of UTI? Mainly in a busy schedule of our clinic, we usually miss the physical examination of the lower urinary tract. What we have to specifically see in case of a recurrent UTI is the mainly the genital, suggest of having phimosis as ballooning during the passing of micturition, as well as labial adhesion and multiple labial and mainly the anal anomalies. The spinal anomalies, what we see is having a spina bifida, lipoma, meningomyelocele, occult meningomyelocele, sacral agenesis, anal atresia. These are all having underlying lower urinary tract abnormalities which are at increased risk of having urinary tract infection. And the next most common cause for the recurrent episodes of urinary tract infection is bowel bladder dysfunction in a children. That should be never missed and should be always treated. You can see the three postures which is mainly presents which indicate the urgency of the symptoms of a urinary tract infection. In the first posture, you can see the child standing with a crisscross, and the others in the second they are in order to delay the voiding, they try to hold the penile with hand. And in the third, the posture in which they made a squatting position to just postpone its urination. It is mainly seen above 5 years in a well-trained, toilet-trained children who have increased risk of urinary tract symptoms, and they are always have a risk of having constipation. And always we have to rule out the neurological dysfunction associated with bowel bladder. The new guidelines is updated with a cutoff value of urine culture. If you have taken a sample to a suprapubic, if the colony count is noted to have equal or more than 10 raised to 3, then it is a significant bacteriuria, then you can consider as a UTI. Whereas when you take the sample through catheterization, this cutoff value has been reanalyzed as equal or more than 10 raised to 4. Whereas in clean catch, it is previously it was only 10 raised to more than 5. Now it is given as from 10 raised to 4 to 5. How do we diagnose an UTI? Any child who has presented with fever without focus, persisting for more than 48 hours, or if the age of the child is less than 2 years, who has high risk of presence of other risk factors, or who has presented with a specific urinary symptoms in the form of a dysuria, lower urinary tract symptoms, then in an initial, we have to do a screening test, mainly leukocyte esterase and nitrates, either of which is positive to consider starting an empirical antibiotic. Both are negative, and if the child is at high risk, having age less than 6 months and having a risk factors with underlying CACOT or having a posterior urethral valve, then in that condition, if it is yes, then we have to start antibiotics. If there is no any risk factor, then send for culture, wait for culture, and based on the culture, you can consider for starting up antibiotics. How do you choose selection post UTI? The evaluation of radiological evaluation. If you have a first episode of UTI, and the child has urine culture which is non-E. coli, and if he is found to be high risk, if the age is less than 2 years or a history of having recurrent UTI, then first we have to go for ultrasonography. In a ultrasonography, what we have to look specifically in this image, in the first image, we have to look for the any renal malformation. That is mainly in this first image. What we can see is severe hydroureter nephrosis, and look for the sizes of the kidney. Whether there is any discrepancy in the size of the kidney, look for the corticomedullary differentiation, whether it is maintained or whether it is a hypoplastic. And always we have to ask for a radiologist to look for the pre-void as well as a post-void, which gives a rough estimation about what is the cause for that. If there is a post-void accumulation of the urine, if it is more than 10 ml, or then it is very much significant. And also, we have to specify a radiologist for looking after the bladder wall thickness. If the bladder wall thickness is more than 3 in a empty bladder or more than 5 in a full bladder, then it is highly suggestive of this is significant. We have to evaluate for it. And the next uh, investigation we have to evaluate is micturating cystoid urethrum. In this, it is mainly indicated to have a UTI with a non-E. coli pathogen who is of age less than 2 years with abnormal ultrasonography and history of recurrent UTI. After the evaluation of MCU, after 4 to 6 months of the UTI, you have to look for the scarring of the kidney with the help of a AMSS scan. It is mainly indicated to have recurrent UTIs who have high grade VOR. How do you treat and prevent UTI? In case of before treating an UTI, you have to differentiate whether this urinary tract infection is whether lower urinary tract or a upper urinary tract. In case of a lower urinary tract, they present usually, which is most commonly seen in adolescent age group, with the symptoms of cystitis, with dysuria, burning micturition, and all. In that children, it has to be treated with oral antibiotics for 3 to 7 days and supportive management. If it is an upper urinary tract infection with pyelonephritis, high risk factors in the form of age less than 2 months with sepsis and renal angle tenderness, if there is a very much poor oral intake, then in that condition, we have to consider for IV antibiotics for 3 to 4 days. When the child is ready to take orally, then we have to shift to the oral antibiotics. And we have it is always to reassess after any UTI for 48 to 72 hours about the clinical response. If the clinical response is good, then shift to oral antibiotic. If there is no any clinical response, then look for the complications associated with UTI. Antibiotics for the treatment, usually we have to start antibiotic as early as 48 to 72 hours. It is mainly indicated in high risk factors to start IV antibiotic in less than 2 months severely ill patients. Then we have to shift to the oral antibiotics. Then when to consider antibiotic prophylaxis if they have a risk factor. The most commonly used is otrimoxazole, nitrofurantoin, and cephalexin. For the age of less than 6 months, always consider for cephalexin than the other two. How do you prevent UTI? Mainly by advising the parent for the going at circumcision or cranberry product. How do you identify how do you evaluate for bowel bladder dysfunction? It is mainly by doing a Whiting diary, which is to know about what is its urine output and how many episodes does he has leaks and what is his urgency symptoms and based on his activity. And when the other thing what we can do is going for Bristol stool chart. How do you manage the case of a recurrent UTI when to refer a nephrologist? In a case of a primary VOR who have a low grade of grade 1 to 2, there are no episodes of urinary tract infection, no need for antibiotic prophylaxis. If the low grade reflux with the UTI, then look for the bowel bladder symptoms. If there is a bowel bladder symptoms, then treat for bowel bladder and continue for antibiotic prophylaxis. If there is a high grade, that is grade 3 and grade 5, in that conditions, with a bowel bladder, we have to continue antibiotic prophylaxis up to 2 years. And the deciding about the stopping of antibiotics in case of a high grade reflux is based on three criteria. If the child is symptom free with UTI for more than 1 year, or if it is well trained and your bowel bladder symptoms has been resolved, that it is been completely treated, then you can stop antibiotic prophylaxis. Otherwise, we have to continue for if there is a breakthrough UTI, then we have to change to the surgical management. Why should one treat UTI promptly? If we won't treat, as we have seen in the first case, that it will progress to ESKD, which might require for renal transplant. So it has been noted that the VOR of grade 3 or higher are high risk of having scarring, which may have which in the future will progress to have a comorbidities in the form of hypertension, proteinuria, and chronic kidney disease. Thank you.
Thank you, sir. The surgical talk over urinary tract infection will be done by Dr. Prasanna Kumar, sir, Associate Professor, Department of Pediatric Surgery, St. John's Medical.
Yeah, let me this last one. How do you push this way? Which is the point? This way? Yeah. Good afternoon, everyone. I'm dealing surgical aspects of urinary tract infection. There might be some overlap. We know nephro and ped surgery will share the common. So conditions with the recurrent urinary tract infection, especially in surgical thing, has to be managed. Either it could be congenital or acquired. Most of them are congenital conditions which has to be treated and treat appropriately. You have to identify what are the predisposing factors, where is the source of organism, and what are the conditions which maintain those favorable conditions. It's a multifactorial, multidisciplinary approach is essential. Specific investigation has to be done to identify the proper thing. So, principles of what is surgical management: identify the etiology, determine the most appropriate surgical option. Common initial procedure should be endoscopic assessment, followed by minimal invasive procedure. Relapsing infections, maybe because of urinary stasis, most common mechanism will be obstruction, especially surgical conditions. Common surgical conditions could be because of procedural adhesions or phimosis, VUR, PUG obstruction, urethral valves, or neurogenic bladder. In the acquired, it could be calculi, it could be congenital because we have seen two cases. Fistulae, foreign bodies, left out stents, catheters for a long duration, neurogenic bladder, gallbladder syndrome, that is dysfunctional voiding bladder, sometimes malignancy, especially RMS can also present with UTI, immune deficiency patients like who are on immunosuppressants or acquired immunodeficiency can present with recurrent UTI. In adolescent, late adolescents, sexually acquired also be considered. So this is one of the commonest conditions where we see usually patients will come with and referred for us for a circumcision. So what I know tell is that till 5 years of age, this is not considered as a pathological. This is a physiological phenomenon. Procedural adhesions, you can see that you cannot see the urethral meatus. They say it is abnormal. So it is okay. It is okay to till 5 years of age. It will over a course of time, like a balloon, it will open up because of recurrent spontaneous erection. What you see, it's a universal during neonatal period. It's the profuse will be supple till 5 years of age. In 90%, over a course of time, lysis and resolution of this provisional adherence will happen, and it will get resolved. Most of the time, in more than 90%, it is managed by simple adhesolysis. Open up, the process will be rectified, and what you see is not a, infective thing. It is just called deformation or exfoliation of the epithelial tissue, what we call as epithelial pus. Low dose of steroids like 0.05 to 0.1% of is recommended for 2 to 3 weeks. Most of the time, it will open up. And no circumcision is required in this condition. Similar in girls, we see what we see is called labial adhesions. It is at the labia minora level, seen in up to 1 to 2 years of age. It is at the epithelial mucosal adhesion. It could be partial or complete. Deeper tissues are not involved, like the skin and the labia majora. And most of the time, it will be asymptomatic, incidental finding, or maybe rarely you can present with